In red blood cell and bleeding disorder pathology, the student must be able to describe the key biochemical and physiologic pathways related to hematopoiesis and specifically erythropoiesis. This includes the glycolysis cycle, vitamin B12 and folate metabolism, and iron metabolism. In hematopoiesis, the student must be able to start with the hematopoietic stem cell and continue that through to the development of a mature blood cell in the circulating blood system and the diseases related to the oxygen binding curve. In addition, the student must be able to use an algorithmic approach to anemia based on red cell size and proceeding through the various testing modalities. These various lab tests must be understood, including their pathophysiologic basis and their use in clinical decision making. The various diseases that are associated with anemia must include for each disease group the presentation of that specific disease, the pathophysiology of the mechanism of disease, and the natural history of the disease. A differential diagnosis of polycythemia is important and must include the ability to diagnose relative, secondary, paraneoplastic, and neoplastic polycythemia. The neoplastic polycythemias, including the myeloproliferative diseases of polycythemia vera, primary thrombocythemia, and myelofibrosis, must be understood at a level of disease presentation, pathophysiology, including the key mutation JAK2, and the natural history of each disease. The student in the bleeding disorders must be able to describe the normal coagulation pathway and place on it the important diseases, the drugs that are used in anticoagulation, and the laboratory testing as it relates to the normal pathway. In addition, the normal pathways of anticoagulant action in the body must be understood, as well as the hypercoagulable diseases. In addition, the laboratory testing must be applied to this group of diseases as well. At the beginning of this chapter, as we do in every chapter, we start with key components of the basic sciences that you have to have for this chapter in this organ system because they are utterly foundational. And this goes beyond just looking at these images and understanding them. These are images that you have to have in your mind's eye. If you can't take a blank piece of paper and write this down, then you don't have it in your mind's eye and you're not going to be able to plot your diseases on it. So as we go through these images, we're going to explain them, but each person has to go away quietly on their own with a blank piece of paper and write them out so that they become part of your mental framework. We start with a very old friend, glycolysis. I know that you're wishing this was biochemistry gone forever, but truly, this is a fundamental pathway for understanding red cell diseases. Let's remind ourselves how this works. We start with glucose. Glucose then is converted to glucose 6-phosphate. Notice where we use glucose 6-phosphate in the cell is G6PD takes it over to the pentose shunt pathway. That G6PD now is going to create NADPH. NADPH is an essential component for having reduced glutathione. Remember, glutathione is absolutely essential for breaking down peroxide so that we don't form reactive oxygen species that give oxidative stress. Moving down glycolysis, glucose 6-phosphate goes to fructose 6-phosphate, goes to fructose 1,6-biphosphate. Now take a look at our rate-limiting step enzyme here, phosphofructokinase. PFK is the rate-limiting step of glycolysis. That's a fundamentally important fact, especially when you combine it with the fact that it is responsive to situations of hypoxia. So note PFK, we're going to come back to this when we plot on clinical relevance. Fructose 6-phosphate goes to fructose 1,6-biphosphonate, goes to glyceraldehyde 3-phosphate. Now note, GAP goes to 1,3-bisphosphoglycerate, and that step is going to create an NADH. That NADH is used by cytochrome B5 reductase to prevent the oxidation of iron from its ferric to its ferrous form. This is going to come back when we talk about causes of congenital methemoglobinemia. 1,3-bisphosphoglycerate, you notice, is the precursor for 2,3-bisphosphoglutamate. This is going to be an essential component of our oxygen binding curve, and it's going to tie directly into the physiology of oxygen. So we're going to come back and use that in clinical medicine as well. We now go through a series of steps that end up at phosphoenol pyruvate. PEP is converted to pyruvate by pyruvate kinase. This is an essential producer of ATP in the glycolysis pathway. It's also going to be one of our common enzyme deficiencies. Pyruvate now is converted to lactate by LDH. So, as working doctors, we're not learning glycolysis because it's good for our memory testing. You can see what we've done now is we've started by plotting red circles for all the disease abnormalities from breakages in this. So let's start and go through them. Number 1 is G6PD deficiency. This is the commonest inherited deficiency of enzymes in the red cell. And we all know the story well, and we're going to discuss it in some detail in the text. When we take a look at phosphofructokinase, remember we said in conditions of hypoxia, the cell upregulates phosphofructokinase. So what that's going to do now is that's going to increase the production down the pathway, and let's follow it down. We're going to increase all the way down to 1-phosphoglycerate, which is going to go to 2,3-DPG. 2,3-DPG is going to right shift our oxygen binding curve and relieve the oxygen deficiency at the tissue level. When do you care about that? Well, let's make this clear. When you walk off the airplane at the Denver airport, which is at 5,500 feet, you have a mild hypoxia. It's going to take at least 5 days for your body to increase your red cell mass. In the interim, in a matter of minutes, your relative hypoxia and the hyperventilation of altitude are going to be responded in the body by increasing our PFK, which is going to increase glycolysis, increase our 2,3-BPG, and give us a right shift in the oxygen binding curve. When we look at the deficiency of cytochrome B5 reductase deficiency, this is one of our inherited causes of methemoglobinemia. Pyruvate kinase deficiency is the second commonest enzyme deficiency of the red cell, and this presents as a severe anemia, highly variable. There's many different variants of it, but it can present early in life as a severe anemia, or it can present later in life as a mild anemia. But one of the things we should look at this metabolic pathway and understand is, why are these children relatively asymptomatic for their degree of anemia? Well, remember, anytime we lack an enzyme, all of the metabolites above that lack increase in number. So if we lack pyruvate kinase, we're going to build up all the metabolites behind it, which is going to give us, at the 1,3-bisphosphoglycerate level, an increase in our 2,3-bisphospho right-shifted oxygen binding curve, and now we again have less severe effects of anemia. Well, we have 2 other facts we have to think through because they matter in everyday medicine. Every cell has the ability to do glycolysis, which means that every cell has lactate dehydrogenase. And if you haven't thought about it, that's just the lab test LDH. So if LDH is present in every cell, it's not a particularly specific marker, but it is a marker of cell volume and cell death. So that when we have, for example, very bulky neoplasms, and 2 commonly bulky neoplasms would be lymphoma and our germ cell tumors of testicle, you can actually use them to calculate the volume of tumor burden, the actual tumor mass in the patient. If you've got really bulky disease, and by bulky that's a term the oncologists use to mean, as big as a melon or as big as a football, you're going to be able to see that there's an elevation of LDH. Similarly, anytime we have lots of ongoing cell death, you're going to see lots of LDH release. So that when you use chemotherapy in those patients, you're going to certainly see good responsive tumor is going to have a marked release of LDH. Similarly, when we get into anemias, when we have problems making red cells get to maturity, such as megaloblastic B12 deficiency, those patients have ineffective erythropoiesis, and they also have elevated LDH. The last is this idea that anaerobic glycolysis is upregulated in cancers. This is our Warburg effect. And the reason that cells probably do this, it's a very inefficient means of energy production, but what it does do is create a lot of precursor metabolites. If you haven't thought through the Warburg effect, this is well discussed in Chapter 1. But we can see to create equal amounts of energy from inefficient glycolysis, which for a given glucose is only going to generate 4 ATP relative to the 36 of fully oxygenating through the electron transfer chain, it means that tumors actually use a lot of glucose. So that if we do a test that follows glucose in the body by putting a tag on it, such as a radioactive fluoride, we can actually go looking for tumor on it. So this whole pathway is the Warburg effect is what we use for our PET, positron emission tomography, in staging cancers. The B12 folate metabolic pathways are also pathways you have to have in your mind's eye. So let's just go through and make sure we understand how we're going to use them in medicine. Note that we need folate to convert uridine to thymidine. And thymidine obviously is a pyrimidine that we're going to use in DNA synthesis. So you can't make DNA without folate. But you notice that most of the folate in the body is 5-methyl tetrahydrofolate. And so that requires a methyl group receptor to become activated. And that methyl group receptor is vitamin B12. So that if you don't have B12 from a deficiency, you can appreciate we can't actually have working folate. And that's the so-called folate trap. What does that vitamin B12 do with the methyl group? Well, you notice it takes homocysteine and adds the methyl group to convert it into methionine, which is widely used in many metabolic processes. In the absence of B12, we see an increase in homocysteine. Remember that homocysteine is an independent risk factor for atherosclerosis. So in any patient in which you see a hyperhomocystinemia, it behooves you to make sure that it's not from a vitamin B12 deficiency. And this is a relationship that is frequently tested on STEP, so you have to have it in your mind's eye. The last clinical relevant point is everyone's very comfortable with the idea that while folate deficiency is associated with anemia, it does not have the neurologic defects associated with vitamin B12 deficiency. And this is not settled science, but it's a reasonable way to think about it to note that homocysteine, through a series of steps, actually is a precursor to succinyl-CoA and fatty acid oxidation. The inability to complete this pathway is problematic in developing insulation of nerves and might be one of the pathways that is responsible for the neurologic defects. When we take a look at where vitamin B12 sits in this pathway of fatty acid oxidation, we note that it's necessary for methyl malonyl-CoA to be converted to succinyl-CoA. So again, remember the rule. If we lack an enzyme, all the metabolites above that lack build up. So in the absence of vitamin B12, we can expect to see an increase in methyl malonyl-CoA. So when you're on the wards in a few months and you're doing your testing, the screening test for vitamin B12 deficiency is to measure the vitamin B12 level. But if you're looking for the most sensitive and specific test, you're actually going to measure methyl malonyl-CoA, which will be elevated in vitamin B12 deficiency. The second point to notice is this: in vitamin B12 deficiency, we will see elevated methyl malonyl-CoA. You note that we will not see that in folate deficiency. So figure 7-13A is iron metabolism. We're going to walk through this, but this you absolutely have to be able to take a blank piece of paper and draw it out in your mind's eye. You're going to see iron deficiency and diseases of iron all your life, and you have to have this way of thinking about it in your brain so that you can understand the diseases and the testing of the diseases. So let's start over here in the gut in the lower right quadrant. You notice that iron has to be taken in through the diet. And you'll notice that it says here heme iron. By heme iron, we mean iron that's actually in meat. Iron that's in meat is much more bioavailable than iron that's in plant material. So that when you're dealing with your borderline absorption patients and borderline diet patients, remember that patients on strictly plant diets have less bioavailable iron than those that don't. Note as well that iron is typically absorbed in the ferrous state. And so the relationship of gastric iron and gastric acid production matter. When you get your older patients with their atrophic gastritis and no acid production, again, they are susceptible to poor absorption of dietary iron. Iron is then taken up in the enterocyte and held there. Now, let's just review a little bit about reactive oxygen species. Remember that we get production of reactive oxygen species by pathologic and physiologic processes. The commonest place to get it from physiologic processes is from our electron transfer chain oxidation. Those are converted under the presence of superoxide dismutase to peroxide. And remember that we have catalase and glutathione to eliminate that peroxide. The danger of iron, remember, is in the presence of iron, that peroxide is converted to our hydroxyl radicals. That's our so-called Fenton reaction. So nowhere ever in the body are heavy metals ever allowed to be free, because all of them are going to precipitate the presence of these hydroxyl free radicals, which are extremely destructive. So when you're watching iron, you're always asking yourself at every step of the way, what protein is binding iron to prevent the Fenton reaction? So the bound iron in the enterocyte is not allowed to leave the enterocyte into the blood unless there is ferroportin. And so regulation of body iron is at the level of the enterocyte. And the regulating protein, which you can see in blue over the liver, is hepcidin. Hepcidin is a protein that the liver produces in response to the liver iron stores. And when liver has abundant iron stores, it produces hepcidin. Hepcidin goes down and binds to the ferroportin, which is the membrane release of the iron, and the ferroportin is internalized and disappears. If there's no ferroportin to allow the release of that iron, then 3 days later, when the enterocyte dies its normal lifespan, the iron is swept away into the gut and not absorbed. The body really has no other way to get rid of iron. So the only way it can control iron is by not allowing it in the first place. Obviously, the only exception to that is menstruating females. So we think of the enterocyte absorbing, releasing through ferroportin in the absence of hepcidin. Remember, iron's never allowed to be alone, so iron is carried on the transferrin and has one of two fates. It's either going to go all the way around to the bone marrow, where it's going to be incorporated in the red cells 85% of the time, or it goes into the liver, where the whole transferrin iron complex is absorbed into the hepatocyte pepinocytosis, and then the iron is clipped off the transferrin, which is re-released, and stored as a special storage protein form, ferritin. The iron that goes into red cells will live the normal lifespan of a red cell, 100 to 120 days. And then remember, the senescent red cell is going to be phagocytized in the spleen and reprocessed by the macrophage. So we know that the hemoglobin, the globin, is going to be eubiniconized and under proteasome broken into peptides. We know that the heme ring is going to be opened and released as bilirubin. And the iron, which is never allowed to be alone, is packaged in a special storage form of ferritin called hemosiderin. Note now, the hepatocyte and the macrophage also have ferroportin to release their iron, and that's also the same site regulated by hepcidin. So when we talk about the clinically relevant parts of this, we have to think about hepcidin. The absence of hepcidin is the commonest defect in hemochromatosis. We're going to be using iron and transferrin to measure presence of iron stores. We're going to be using ferritin as a measure of iron stores, and we're going to be using hemosiderin as a universal marker in macrophages for the presence of previous bleeding. So this is a really important diagram, and it's foundational in medicine. So make sure that you can take a blank piece of paper and start with some heme iron in the gut and walk it through its life cycle. So all we've done now is we've taken the picture of erythropoiesis from our previous image, and in figure 7-1.4, we've actually made it as a schema. So you can see at the top, HSC is our hematopoietic stem cell, and you can see we've broken it on one side into the common lymphoid precursor, but today we're interested in anemias, so we're at the common myeloid progenitor. Note that we have our two families. We have our granulocyte monocyte versus our erythroid megakaryocytic. We're doing anemia bleeding disorders, so we're interested in that latter family. You notice we have megakaryocytes and erythroblasts. We're doing anemia, so we're going to come down erythroblasts. And now all of a sudden you notice we're going from the nucleated erythroblast with the loss of the nucleus and the release of the anucleated red blood cell into the blood. So note we have that really profound barrier between marrow and blood. When we talk about a red cell, we always think about a red cell as having a membrane, some protective enzymes, and hemoglobin. When I say hemoglobin, this is what I think of. I think of as heme and globin. When I say heme, I think of the tetrapyral ring and the iron in the center of it. And so you can see we've got our hemoglobin molecules and we've got globin, heme, and iron. But the story doesn't stop there. We don't have red cells for red cells. We need red cells because they hold the hemoglobin that's going to pick up our oxygen at the lung and deliver it to the tissues. So there's no point in talking about this whole process without ending up at the oxygen binding curve. Great. We've done all this work to know normal, and frankly, no one cares if it doesn't apply to the practice of medicine. But look what happens now when I plot all of our diseases on this schema. What are some of the diseases we see, starting at the top, with the hematopoietic stem cell? Well, aplastic anemia. When we cover aplastic anemia later in this chapter, and I say to you, it's presumed to be an autoimmune destruction of the hematopoietic stem cell, well, it's pretty obvious. Everybody disappears downstream, don't they? And that's going to be our pancytopenia. CML is going to be a 922 translocation in the hematopoietic stem cell. No one really understands why it's completely restricted to the granulocyte series, but it is a hematopoietic stem cell defect. Acute leukemias are diseases way up high in the immature stem cell level. And MDS, standing for our myeloid dysplastic syndromes, are going to be extraordinarily common in your practice because they're diseases of old people. And if we think of these as our pre-leukemias, and you understand they're occurring at the level of the stem cell, you can appreciate accumulating mutations causing pre-leukemias at that level must have a very ominous prognosis and a high conversion into acute leukemias, and the answer is that's exactly how you should think of them. Okay, well, let's come down now into our family with our erythroid megakaryocytic progenitors. This is now in myeloproliferative diseases. This is the level of our JAK2 and other mutations. We mature down from the erythroid to the erythroblast series through EPO, and this is where we're going to see the normocytic anemia of chronic renal failure. And for your generation, you're not going to see chronic renal failure as uremia. That's really third world stuff. Your commonest presentation of chronic renal failure is going to be fatigue from anemia. All of your hemolytic patients with their rapid turnover of red cells go into aplastic crisis when they have a parvo B19 infection. Parvo B19 selectively infects the erythroblast due to the surface P antigen, and we get this temporary shutdown for 1 to 2 weeks of erythropoiesis because of the viral infection. And this is how we're going to think of that parvovirus action. When I get metastases to a bone marrow, when I have granulomas from extrapulmonary tuberculosis, I get architectural damage to the bone marrow. And I can see that because I see release from the bone marrow of immature cells. This pattern of having damage to the bone marrow by mass-forming lesions like metastases and granulomas is myelophthisis. So when we discuss myelophthisis later in the chapter, you should have this mental picture in your mind of we've structurally damaged the marrow, and we know that because we're getting release of immature cells. When we look at our diseases actually in the red cell, well, what are our diseases of membrane? Congenital versus acquired. The classic congenital disease of membrane is hereditary spherocytosis. But when you think about it, our immune diseases are actually acquired diseases of the membrane. If we have immunoglobulin G, or we have complement fixed to our red cell membranes, we know that they're going to be selectively filtered out in the spleen, and that's going to give us a hemolytic anemia. So acquired diseases of the membrane should be thought of here. Two common enzyme deficiencies, G6PD and pyruvate kinase deficiencies, are at the enzyme level. When we talk about globin diseases, they are quantitative. They're normal, but you're not making enough of them. Versus qualitative. There's actually an error in the protein sequences. Well, quantitative, that's our thalassemias. Qualitative, there are over 200 hemoglobinopathies. So we traditionally are going to use hemoglobin S, sickle disease, as our model disease for all of the hemoglobinopathies. Abnormalities of tetrapyral ring, our heme ring, are generally lumped under the family of sideroblastic anemias. This is a large and complex group, so from your perspective, what you need to know is lead toxicity. That's going to be our model disease for this complex large family of diseases, and that's a really good place to start. And then, of course, we have two diseases of iron. We have iron deficiency, that's very common. And then, of course, we have diseases in which hepcidin is increased so we don't get release of it, and that's going to be our anemia of chronic disease. But remember, this is not about the red cell. Why do we need hemoglobin? So you should never think of hemoglobin without thinking of your oxygen binding curve. So let's take that curve, which we've got a nice picture of here, and let's just make sure you understand the really big ideas that you're going to use in clinical medicine. So let's go to the top of the curve, and we're going to draw in, remember on the bottom we have the oxygen, PaO2, and then on the y-axis we have percent saturation. So if we go over to the upper right of the curve, we have roughly 100% saturation when our PaO2 is 100 millimeters of mercury. So that's always a good place to start. So think through then where we go down to tissue level, which is 30 to 40 millimeters. And you can see, isn't that just absolutely elegant? Our curve is 100% saturated in the lung, where our PaO2 is 100. And when we get down to the tissues, we can see we're absolutely on the nice drop-off part of our curve so that the hemoglobin is now going to release the oxygen. You've covered this in physiology, so let's just add one more clinical point. It's called the ICU point. And if you haven't seen this, it really helps you think this through, because you're going to make every effort you can to always keep your PaO2 of your blood gases greater than 60 millimeters. Yeah, let's take a look at why that is. I'm going to plot 60 millimeters on your curve. There it is right there. So there's going to be 60 because that's going to correlate to 91% saturation. That's going to functionally work as a perfectly normal oxygen delivering level. But the second you start letting it drop below 60 millimeters mercury, look where we are. We're just crashing down the steep part of the curve of our percent saturation. So you can see, we haven't done a single subject here, have we? We've done some cellular with the hematopoiesis. We've done some biochemistry with our structure of hemoglobin, and we've done some physiology with our oxygen binding curve. But now, as you go into clinical medicine, they all come together as a way of you thinking about basic sciences and clinical disease. So, as with all of our systems, we have to have a way of going from basic sciences to disease, but by the same Gerard-Osler discussion that we had back in Chapter 1, every clinician has to have a way to go from patient to basic sciences. And what we see in Figure 7-2.1 is probably the commonest working clinician's way to approach anemias. So we're just going to spend a little time here to make sure you understand how to do this. MCV refers to mean cell volume. There are going to be 3 tests you never have to justify in medicine. Those 3 tests are going to be urinalysis, a complete blood count, CBC, and a metabolic panel, your chemistry panel. Those you're going to see basically every day on every hospital patient, and you're going to order them extremely routinely in practice. So you never have to justify them, but because you're going to start every day as a clinical clerk looking at 30 of them, you really have to be used to handling them quickly and getting the right conclusions from them. So you notice what we get out of the CBC, one of the parameters we get out of the CBC is the MCV. So every morning you're going to be looking at your patient's CBCs, and MCV is something that you're going to have universally available. And so you can see we divide our anemias, a low hemoglobin or hematocrit, based on red cell size. If our red cell is less than 80 femtoliters, it is microcytic. And as a universal rule, all of our microcytics have an inability to make hemoglobin. And there's 4 basic diseases that give us that as we look down. By far and away the commonest is going to be iron deficiency. And look at the ways we diagnose iron deficiency. We can do the carrier protein in the blood. Total iron binding capacity is an indirect measure of transferrin. We can measure ferritin, which is a measure of total body iron storage, or we can actually just take a piece of the bone marrow and see if we have macrophages containing hemosiderin. So when I said you really have to have a way of seeing iron metabolism that we discussed in Figure 7-1.3a, you can see all of the steps we used in that are used in clinical medicine to evaluate iron status. If a patient isn't iron deficient, traditionally the next test you're going to look for is to rule out beta thalassemia. So hemoglobin electrophoresis can measure hemoglobin A2 and F, and those are elevated in beta thal. Other diseases that have hemoglobin synthesis deficiency, the commonest you're going to see in hospital is going to be anemia of chronic disease. Well, anemia of chronic disease really is seen in malignancy and in situations of systemic inflammation. So that's really not a diagnosis you make by test. It's a diagnosis you make on clinical history. Remember, we talked about our sideroblastic anemias, but in everyday medicine, by far and away the commonest is lead toxicity. So lead poisoning becomes our model disease for all the sideroblastics. And then the alpha thalassemias really don't have a diagnostic test, so they become a diagnosis of exclusion. Well, that takes a big chunk of our important anemias and really lays them out to be diagnosed quite straightforward manner. The next group that's quite easy to deal with are the large or macrocytic anemias. By and large, these are diseases where I have an inability to make DNA. There's a few in there that you're going to see are actually membrane, but we think of this as a DNA synthesis group. And by far and away the commonest cause you're going to see is right here, abnormalities of B12 and folate metabolism. You're never going to have a patient with a macrocytic anemia. You're not going to check the B12 and folate level. If those are low, then we can see they're over in the larger size of the macrocytics. Typically these are larger than 110 femtoliters. And we're going to see here, if they're low, that's our megaloblastic anemias. The other important family with a strikingly large macrocytic anemia are our MDSs, are myelodysplastic syndromes. And that's a pretty unwieldy term, so if you just want to think of those as pre-leukemias, that they were known as that for decades. You'll notice, though, that you can get this mild macrocytosis. You have this funky little group here under the less than 110 femtoliters. Well, chemotherapy, no surprise there, because most of our chemotherapies interrupt DNA synthesis, so that makes perfect sense. But these other diseases, liver disease, reticulocytosis, and hypothyroidism, they're poorly explained, maybe related to membrane. You just have to know that they exist because you're going to see them in practice. That then takes us to our largest group, which is our normocytic anemias. And get the big picture right. It's either due to increased destruction, that's universally called hemolytic anemia, or it's due to decreased production, and that's going to be non-hemolytic anemia. And the way we differentiate those is reticulocyte count. So we're going to spend some time talking about retic counts because that's a pretty important test for a fundamental and common type of abnormality. If there's an elevated retic count, meaning there's increased destruction of red cells, hemolytic anemia, then we have to decide, is it immune or non-immune? And so this is where we're going to have to need a Coombs test. Positive Coombs test is my immune hemolytic anemias. If it's not, then typically we're going to go look at our blood smear, because you can see, and the schistocytes are really there for medical students just so you can keep it clear in your mind, because you notice we see schistocytes in our microangiopathic diseases. Commonest was going to be DIC. That's a very sick patient. It's not like you're going to need this algorithm to figure out you have a really sick patient. But from a medical school testing perspective, it's a good place to remember this is where schistocytes really have an important role. Basically, if you have a non-immune hemolytic anemia, you're with your big three congenital groups. It's an abnormality of membrane, hereditary spherocytosis. It's a hemoglobinopathy, that's going to be sickle cell, or it's going to be an enzyme deficiency. By far and away, G6PD deficiency is commonest. All that leaves for discussion then is decreased production or non-hemolytic anemia. And functionally, you have to decide, is the factory broken, that's our bone marrow, or is the factory making normal amounts of red cell and something else is going on? Well, we don't want to make this an overwhelmingly complex discussion, so basically what you're going to do is do a bone marrow biopsy. If you have a normal bone marrow, you're really talking about diseases like renal failure with no EPO or anemia of chronic disease with too much hepcidin. All the rest of the intrinsic problems you can see and diagnose by bone marrow biopsy. The only other disease to point out here is if you have non-hemolytic decreased production, a large spleen can give us hypersplenism and so-called sequestration. You're going to be really impressed how many questions are on anemia in your exam. There are a lot. It's a long exam and it's really tiring. This algorithm you're going to use every day of your life in medicine, and it's really fundamental and absolutely useful thing to take into your exam. So get a blank piece of paper, and as many times as it takes you to write out, this has to be in your head going into your exam. It's going to help you through the whole exam in two ways. First of all, you'll get your questions right, but second of all, they're going to go fast and it's going to let you save energy. So I'm not doing this anemia algorithm because it's interesting to look at. This is something you have to be able to do yourself. Well, Table 7-2.2 is more a discussion of a general approach to hematology. We're going to talk about how your patients present with hematologic diseases, but remember, people that present with complaints get CBCs. So if we start on the left side of the table, you see we start with what you're always going to have in hand, which is your CBC. And you can see our CBC is going to point out if there's an abnormality, it's going to be in one of two groups. Either there are too few of a type of cell, that's going to be a cytopenia, or there's too many of a type of cell, there's a proliferation. So if you have a cytopenia, or you have too many of a type of cell, the next thing you're going to do is you're going to get a peripheral blood smear and look at it. And that's really important because there's two entities that absolutely can only be diagnosed morphologically. The presence of blasts equals acute leukemia. So a patient's going to come in sick, you're going to have a abnormal CBC. Typically it will be an elevated number of leukocytes. You look at them on the peripheral blood smear and their blasts, you have acute leukemia. The other group is going to be when you have immature leukocytes, so-called left shift, or nucleated red blood cells. The presence of immature leukocytes and nucleated red blood cells is called leukoerythroblastic smear. And that's going to be one of two diseases. It's either going to be myelofibrosis, a myeloproliferative disease, or it's going to be bone marrow metastasis. This falls under the heading of myelophthisis. If it isn't clear from the CBC and the peripheral blood smear, then the next thing you're going to do is you're going to go and say, let's go to the organ that makes all these, and that's our bone marrow. So that you can see if you have a cytopenia because the marrow isn't making any cells, well, that's what aplastic anemia is. If you have a cytopenia, but the marrow is hypercellular, that tells you you have ineffective hematopoiesis. And that's two fundamental diseases. It's either our myelodysplastic syndromes, our pre-leukemias, or it's our megaloblastic anemia in which the cells are being produced, but because they can't make the right amount of DNA at the right time, all those cells are undergoing apoptosis in the marrow and dying. So while you have a lot of activity in the marrow, nothing's getting out. You have a hypocellular periphery and a hypercellular marrow. When we look at the proliferative diseases, well, blasts equals acute leukemias, so that's straightforward. But the other group to consider is if you have too many of a cell, and you look at the bone marrow and all those cells are being produced, then your basic question is this: is it neoplastic, which is our myeloproliferative diseases, or is it reactive? And those are our leukemoid reactions. So as we go through our diseases, and we're going to talk a lot about how patients present, you should have this orderly progression of investigation in your mind. CBC, peripheral blood smear morphology, bone marrow. If you can keep that sequence and the general idea of each, it will serve you well through your entire practice years, and that is the best way to get ready for your exam. So lab testing is really important in hematology, and you really have to understand your lab tests very, very well. So let's spend a little time and do our first introduction and the end of second year medicine for something that's going to be part of your life, hours of every day, whether you're in the clinic or in your office. So remember, anemia is by definition a decrease in red cell mass. Well, we don't have a way to directly measure red cell mass. So what you're left with is estimating. And when we take a look at figure 7-2.3a, we can see what we have to understand in how we measure hemoglobin hematocrit. On the left side, you can see we've started with a whole blood sample. And in this case, we're calculating hematocrit, so just to keep the discussion simple, we've centrifuged it. Red cells are heavier than plasma, and so all of our red cells have settled to the bottom. So the problem we see here is, you notice we're not just measuring red cells. When you take whole blood, you're measuring both the red cells and the plasma. So we do those as a ratio. In this example, we can see that 80 millimeters of blood has 36 millimeters of red cell. 36 over 80 is a 45% hematocrit. Now, why do we always mention hematocrit and hemoglobin together? And that's fundamentally because of the rule of 3. The hematocrit is always 3 times the hemoglobin. And your clinicians are going back and forth so fast doing that, you don't realize they're making the calculation, but that's something that you should just understand everyone does. So in this example, if I have a 45% hematocrit, that would be the same as a 15-gram hemoglobin. And you appreciate the problem that we face here. If I have a patient that's really dehydrated, think what's going to happen. I've got a shrinkage of plasma, and it's going to make it look like I have a higher hematocrit from a red cell mass, but in fact it's from a decrease in plasma. Similarly, if I've overhydrated a patient, I'm going to look like I have a decrease in red cells, but in fact the change is not in the red cell series, the change is in the plasma. And so that's the trade-off we have to be well aware of for using whole blood as an estimate of red cell mass. Well, hemoglobins and hematocrits really have wide physiologic variation. When you get out in life, you're going to realize it's about plus or minus a gram per day. So if your patient's 13.5 grams of hemoglobin today and 12.6 tomorrow, that might not be a drop in hemoglobin. That just might be normal physiologic variation. And some of the things that are always present is, for example, gender. Males have a higher hemoglobin than females. Adults have higher hemoglobins than children. And remember, people that live at high altitudes like Denver have higher crits than people who live at sea level like Los Angeles. We've discussed how hemoglobin and hematocrit are affected by plasma volume. So remember, dehydration can give you a falsely reassuring hemoglobin in an anemic patient. And one of the things we have to be very clear is plasma expansion in pregnancy. Because in pregnancy, the plasma volume increases 50%, but the red cell mass only increases 30%. So you're going to look at that and it's going to look like an anemia, but in fact it's only a relative anemia. The red cell mass is actually increased. Well, you have to be able to compare the CBC and the peripheral blood smear. One is an electronic measure and the other is a morphologic level. So let's start by looking at our CBC parameters. You can see that, first of all, we start with hemoglobin and hematocrit out of our CBC. That's fine. And then we get to the indices below that. Our whole algorithm hinges on mean cell volume. So that's a pretty important discussion. And you can see we just have in words here what we know from our algorithm: microcytic, disorders with decreased production of hemoglobin; macrocytic, defect in DNA synthesis; and then our normocytic. Remember, the big division of normocytics is increased destruction, hemolytic, decreased production, non-hemolytic. Another useful indice is to look at mean cell hemoglobin concentration. And this really measures the ratio of the concentration of the hemoglobin to the volume of the cell. Certainly if we have decreased hemoglobin synthesis, that is going to be all of our microcytic anemias. We have a decrease in mean cell hemoglobin concentration. When we compare this to the peripheral blood smear, that's hypochromia, less red color in the red cell. But one of the really nice uses you can have is supposing I have a disease in which I lose cell membrane. So anytime I lose cell membrane, such as hereditary spherocytosis, or in my immune hemolytic anemias, I lose more membrane proportionate to the amount of hemoglobin, and so I'll see an increase in MCHC. Red cell distribution width simply is a plot of how big all of my red cells are as a population. If we take a look at figure 7-2.3b, on the left side we can see that normal 2 standard deviations of red cells are plotted there. And so that calculation of standard deviation of size is given the units of 15. But think through how we can use this. Remember that reticulocytes are larger cells. So if you have a patient that's had blood loss at surgery or blood loss due to trauma, when those reticulocytes start responding from marrow production, we can actually see that. So let's take a look at figure 7-2.3b and let's look at the right side now, because we can see here that shoulder developing really represents the shoulder of a second population of cells. And that second population of cells represents our reticulocytes. So when you're making sure that your patient is responding well to hemorrhage, you're going to be able to see a slight movement of the MCV, and of course, being a larger cell, we're also going to see an increase in the RDW. So these are summarized in table 7-2.3a. We can see that microcytosis, normocytosis, and macrocytosis, the terms we use for morphology, translates into how we measure femtoliters by MCV. Hypochromia translates into low MCHC. Spherocytes, be it hereditary spherocytosis or an immune hemolytic anemia, greater than 33. And then variability in cell size is our RDW. So we've talked about the CBC, but be aware that the peripheral blood smear is a very, very routine part of everyday medicine. And the only way to really practice the peripheral blood smear, which is morphology, is by looking at the picture many, many times. So what we've done is we've made a nice summary table for you in Appendix 1 so that you can go through and take the shape and understand the significance clinically, or you can take a look at the clinical description and imagine what the red cell shape is. There's no really easy way to do morphology except by practice and repetition, and that's what Appendix 1 does. Well, iron studies. Iron deficiency is extraordinarily common. So we're all the way back now to our discussion of iron metabolism. There are basically 3 studies that we use to look for iron stores in the body. Iron saturation is really a calculation of serum iron over the total iron binding capacity, which is an indirect measure of transferrin. Normally, transferrin is saturated to about the 25 to 50% level. If the transferrin saturation drops below 15%, that's characteristic of iron deficiency. You can actually get oversaturation in hemochromatosis, and if you have a patient whose saturation is over 35%, you really have to rule out hemochromatosis. It's not a sensitive test, but hemochromatosis is quite common, and as you follow your tests of your patient, you really have to know that. One of the problems with using iron saturation is that in chronic inflammatory states, the liver produces less transferrin. So it becomes very difficult to use saturation in chronic disease because of this decreased production of transferrin. The commonest test you're going to use in everyday medicine to look for iron stores is ferritin. So remember, ferritin is the major iron storage protein in the cell. It reflects total body iron stores. And if it's low, that's less than 10 to 15 micrograms per deciliter, that is diagnostic of iron deficiency. Levels higher than that reflect adequate iron stores, with this huge caveat. And here's the problem with ferritin. Ferritin is an acute phase reactant. So remember what acute phase reactants are. Acute phase reactants, often referred to as APRs, are a family of proteins that are produced in the liver when it is stimulated by IL-6. IL-6 is one of our major inflammatory cytokines, IL-1, TNF, IL-6. So anytime I have systemic inflammation, IL-6 is going to stimulate the liver to produce this huge complex family of acute phase reactants, one of which is ferritin. So the problem is, if you have a patient with rheumatoid arthritis or lupus or active tuberculosis, they could well have an increased ferritin as an inflammatory response, and it's going to mask the fact that they might have iron deficiency. And that's the huge problem in the diagnosis of anemia of chronic disease. That said, low ferritin does equal iron deficiency in any situation. So we can see then that it's problematic using serum iron saturation and ferritin in inflammation, because transferrin goes down in inflammation and ferritin can go up. And if you have a very complex patient and you really have to know the answer, then at the end of the day, you just have to go look in the bone marrow. So hemosiderin is the storage form of iron in macrophages. If you can't tell iron stores, you can do a bone marrow. If they're iron deficient, there is no iron present. Not just a little bit. Iron deficiency has no stainable marrow iron. Every bone marrow that you ever do will have a Prussian blue stain, and the pathologist will say, Prussian blue iron present or not. Iron deficiency has no iron, and that's the gold standard for differentiating iron deficiency from anemia of chronic disease. So table 7-2.3b really summarizes all these tables. And this is something that you should have in your head. You're going to use it every day in medicine, and it's going to come up many times as part of the question discussions you have on your exam. So it's really important you understand it. So you can see we have our 3 diseases: iron deficiency, anemia of chronic disease, and hemochromatosis. And you can see straight out of iron metabolism, isn't it? Serum iron and transferrin gives us a % saturation. Ferritin is our storage protein. And bone marrow allows us to look for the presence of iron in the macrophages and erythroblasts of the marrow. So the reticulocyte count is fundamental in normocytic anemias. You don't need it for any of the others. If you have a normocytic anemia, your next step is going to be a reticulocyte count, because you have to differentiate increased destruction, hemolytic anemia, from decreased production, non-hemolytic anemia. So the reticulocyte is a red cell very recently released from the bone marrow. Remember, nucleated red cells, normoblasts, are never normal. But after that nucleus has been plucked out of the red cell, there still is this residual ribosomal RNA left. And that persists for 1 to 2 days after the red cell is released. So you can do a stain, a supravital stain is what's commonly used in the lab, to look for the presence of RNA as a way of measuring how many reticulocytes are present. So reticulocytes actually have a purple-bluish color from this RNA, so on your everyday smear you can often identify reticulocytes, but if you want a reticulocyte count, you've got to ask your lab for the test. They will do a supravital stain, and they will count them and give them as a percent out of 100 cells. Well, our normal red cell lives 100 to 120 days, so we really shouldn't have more than 1 to 2% reticulocytes. If we do have more than that, then that's an indication of hemolytic anemia. There's a problem with reticulocytes. Just like with every test, you've got to know how to use it. And the problem with reticulocytes is this. We don't really want to know what percent reticulocytes. What we really want to know is, are there an appropriate number of reticulocytes relative to the degree of anemia? Because as you become more and more anemic, and your kidney responds by producing more and more erythropoietin, we should have earlier and earlier release of reticulocytes from the bone marrow. So while you can do a quick eyeball check of your reticulocyte count, if you really want to think about them in the best way, you really want to say, how is my reticulocyte production relative to my degree of anemia? So every laboratory is going to do that correction for you, and it's going to do the calculation and give it out as a reticulocyte production index. And what follows in our text here is an actual technical discussion of how that works. First of all, we correct for degree of anemia by saying, well, what if the person's hemoglobin or hematocrit was 45%? So the first thing we do is we normalize the retic count by imagining, well, if we made that 45%, how much would that increase the retic count? The second correction we have to make is then to say, well, as you become more and more anemic, the reticulocytes are released younger and younger and younger. So you have to do a correction for severity of anemia and the increasingly immature reticulocyte counts. So in figure 7-2.3d, we see what that correction is. At the top, 45% is a normal hematocrit, and we can see that the reticulocyte typically has RNA lasting for about a day. But notice more and more immature reticulocytes as we become more and more anemic. So that by the time we have a hematocrit of 25%, notice now that there's such immature red cells that the RNA is going to last for 2 days. By the time you're severely anemic, a hematocrit of 15 is a hemoglobin of 5, notice now the reticulocyte RNA is present for 2.5 days. So the discussion then gives an example of a patient's given reticulocyte count and the correction that we walk through for hematocrit and the correction we walk through for immaturity, and that gives you a much more faithful and reliable clinical discussion of whether there's increased reticulocytes from a hemolytic disease of increased consumption or a decreased count from decreased production. The last test that we want to talk about is the Coombs test. Coombs test is also called the anti-human globulin AHG test. And really all it does, as we learned in immunology, was it looks for the presence of immunoglobulin on the red blood cell. So let's look at figure 7-2.3e. On one side, and in this case we're using an example of hemolytic disease of the newborn, on this side we can see that the red blood cells of the baby have immunoglobulin on their surface. I collect a specimen of those red cells and I wash them, so all I have is the red cells. There's no serum or plasma present. I then take a pre-made antibody that is an anti-IgG. That then binds up the IgG in the red cells so that when I actually look at the tube, the red cells now don't perform a nice homogeneous, but actually all agglutinate and look like little red snowflakes. So this is something that when you get to your hospitals, you should go and try for yourself so you can see it in your mind's eye. But you're just going to take the red cells, wash them, drop in the anti-human globulin, and give it a shake. If they all bind together, agglutinate, then they look like snowflakes, and you know that there's immunoglobulin on your patient's red cells. If they don't, they just look like very homogeneous red color, then you know it's not, and that's going to be a negative Coombs test. Well, acute blood loss is very dramatic clinically and is a very important discussion as you start your clinical years. and very important discussion for understanding the pathophysiology of hemoglobin versus blood volume. If we start with our typical 150-pound adult, that person has about 5 liters, 5,000 milliliters of whole blood. That's roughly about 15 units of packed red blood cells, given that a unit of packed red cells can actually increase your hemoglobin about 1 gram %. We know that the human can tolerate the loss of 5 to 10% of blood volume over 15 minutes with very few symptoms. And you know that because obviously that's what we do when we donate in the blood bank. But when you get acute hemorrhage more than 10% of blood volume, that's enough blood volume to give you hypovolemia. The pathophysiology now is not oxygen carrying capacity from low hemoglobin. It is not that. When you start losing acute blood, it is hypovolemia. And the organs that fail first are the organs that have a high blood supply, like the brain and kidney. So the major first complications of acute hemorrhage are going to be loss of consciousness and acute renal failure. And now we start a straightforward physiologic discussion. How does the body know that we have decreased cardiac output, which is the consequence of hypovolemia? We're back to the baroreceptors in the carotid sinuses and the aortic arch, and they're going to have a sympathetic release of epinephrine. The hypothalamus is going to release ADH, and the kidneys are going to activate the renin, angiotensin, aldosterone system. The body's going to respond with fluid shifting from the extravascular to the intravascular system, and that takes hours to a day or so. But that will result in hemodilution. So remember that when your patient first appears 1 hour after the hemorrhage, there has been no time for these fluid shifts, and your CBC will be relatively unaffected. But over 1 to 2 days, we're going to see that hypovolemia with fluid shifts transition into anemia as we restore our plasma volume before we're able to make more red blood cells. Well, that relative anemia obviously gives decreased oxygen delivery to the kidney, and the peritubular capillaries have specialized cells that detect that hypoxia. This then induces hypoxia inducible factor, HIF, which is going to upregulate production of erythropoietin. The erythropoietin is going to increase our erythroid progenitor cells and decrease their apoptosis in synthesis. That's going to give us a rise in hemoglobin levels, which is going to start after 5 days. If the blood loss is ongoing, we can increase production 4 to 5-fold. So Table 7-3.1 summarizes what you're going to see clinically from this pathophysiologic response. At 10 to 15% blood loss, we're going to start seeing our first of our sympathetic responses. So we're going to see a rapid pulse, increased respirations, and if the patient tries exercise, they'll feel shortness of breath. If they sit upright quickly, they might well feel lightheaded. When we've lost more than 20%, say a liter in your average male, now we're going to start to see shock, which you'll remember the definition is hypotension. Certainly, this is a good time to lie your patient flat, because to keep pumping uphill for an upright patient can be problematic and lead to fainting. When the patient has lost more than 30%, we now go into profound shock and we start to see organ damage. There'll be confusion, air hunger, and hypotension. So make sure as we understand this pathophysiology, there are really important clinical implications. First, acute hemorrhage is a problem of decreased intravascular volume, not the O2 carrying capacity of the red cells. Well, the clinical effect of this obviously is you want to expand volume. You don't have to have red cells. Any volume will do, so you can use crystalloid fluids. Remember, the blood pressure is going to be sustained by the endocrine efforts. So when we have our epinephrine and we have our angiotensin II, we're going to be able to keep blood pressure in a normal range through quite a lot of blood loss. So if you're counting on blood pressure to diagnose effects of blood loss, it's going to be a late finding. Better is to use heart rate, respiratory rate, and skin color to diagnose significant hypovolemia. Just some connections to pharmacology. Obviously, these effects are all from sympathetic response. So if your patient's on beta blockers, the heart rate isn't going to be very useful. Remember as well that initially we have no fluid shifts. So when your patient first arrives into the office or into your emergency room, you're going to see a normal hemoglobin and hematocrit. It's going to take hours to perhaps the next day to see the fluid shifts and the resulting hemodilution. Remember as well that it takes time to upregulate our erythropoietin and expand our erythroid precursors. So you're really not going to see new red cell production for at least 5 days. And as we discussed when we did indices, you can start to see that happen because we see the increase in the RDW and the MCV as the effect of the larger reticulocyte. Chronic blood loss is a completely different clinical picture. When anemia occurs over weeks to months, the total blood volume is going to be normal, so we're not having any of these sympathetic response discussions. Changes in the cardiac output and the regional blood flow can help compensate for the loss of the O2 carrying capacity. Remember, as we discussed when we did our glycolysis metabolic pathway at the beginning, hypoxia induces upregulation of phosphofructokinase, the rate-limiting enzyme of glycolysis. That's going to result in increased production of 2,3-BPG, and we're going to get a right shift of the oxygen binding curve, which facilitates O2 offloading. When we start to see the hemoglobin drop more than 3 grams, that's when we're going to start to see the symptoms of fatigue and loss of stamina and breathlessness with exertion. So if a typical male at sea level has a hemoglobin of 14 grams %, we really don't expect to see any effects of it until their hemoglobin is under 11. Similarly, if a typical female at sea level has a hemoglobin of 12 to 13, we're really not going to see any symptoms at all until the hemoglobin is below 10. And again, what is the classic presentation complaint of your patient in anemia? Fatigue. We also have to pay attention to the difference between acute hemolysis, whether it's intravascular and extravascular. So remember, in intravascular hemolysis, the red cells are literally rupturing inside the blood vessels. We get free hemoglobin, so we have hemoglobinemia. Does hemoglobin clear the glomerulus? Yes, it does. So we're also going to have hemoglobinuria. Remember, we have a protein to mop up the small amounts of free hemoglobin we get in everyday life called haptoglobin. There really isn't very much of it. So with any kind of clinically significant intravascular hemolysis, haptoglobin basically is unmeasurable. And then remember, hemoglobin can be nephrotoxic. So if we see a big enough hemolysis and enough clearance of the hemoglobin into the tubules, we can actually develop renal failure because of the tubular casts of hemoglobin and their ultimate toxicity to the renal tubular cells. Yeah, extravascular hemolysis shouldn't even really be called hemolysis, should it? It's not lysis or destruction of the red cell. It's really phagocytosis of the red cells in our macrophage monocyte system. So we're talking mostly spleen and possibly liver here. So we call it extravascular hemolysis, but we should really think of it as being a phagocytic process. So we don't see free hemoglobin anywhere. Instead, we see jaundiced, because remember, our He ring is forming bilirubin. We see splenomegaly. This is classic hyperplasia. We see gallstones. These are going to be bilirubin stones. And then because we have increased destruction, we're going to see an increase in reticulocyte count. So let's go through and start our specific diseases, starting with traditional microcytic anemias. And you can see now, as we go through all of these, we're going to have this algorithm through every phase of the discussion, because this algorithm has to be something that you have in your head. I should be able to go to any student with a blank piece of paper and say, please tell me your approach to anemias, and you should be able to write this out. So you can see where we are now. We start with MCV. These are our small red cells because they all have in common decreased red cell production. By far and away the commonest is going to be iron deficiency. Remember, the universal presentation of anemia is fatigue. As we note in the right column, the weakness tends to be more pronounced in iron deficiency because remember, we need iron for all our heme structures. So when we ask ourselves, well, what are all the heme structures? Well, 85% of our heme is hemoglobin, but the other 15% includes cytochrome C from our electron transfer chain. We also see it in myoglobin, which is an oxygen-storing protein in muscles. And remember, we also see it in the P450 cytochrome. So that if you have decreased cytochrome C, you have a diminished capacity to make ATP, and you often see fatigue associated with that. Well, people with low hemoglobins tend to be paler. If it's a profound enough anemia, you have tachycardia because they have to increase cardiac output because there's less oxygen carrying capacity. Figure 7-4.1 shows this spooning or scooped shape of the nail called koilonychia. As with all vitamin deficiencies, this is not in any way unique to iron. We see it in all the vitamin B deficiencies, is we see this redness of the tongue. It's a misnomer. It's called glossitis, but it's not an inflammation. It's just a thinning of the squamous mucosa, and it's presumed you can see the blood underlying it easily, so that any situation in which we have a thinning of epithelium, and that's true of all of our vitamin deficiencies, we see this red tongue with the misnomer glossitis. It has been described that esophageal webs form in iron deficiency. This is the so-called Plummer-Vinson syndrome, and these patients often have a sensation of dysphagia. Remember as well that iron is better absorbed in the ferric state, and this occurs in an acid environment. So in your very old people that have achlorhydria, that's a common association with iron deficiency in the elderly. So what is the mechanism of disease? Remember that iron is bound to heme in hemoglobin, and that heme is held in the porphyrin ring to allow the response and shift of shape to the binding of the oxygen. And remember that binding is through a number of histidine amino acids. So when the iron binds to oxygen, it causes a conformational change in this hemoglobin protein complex that allows for easier binding elsewhere in the heme ring, so-called positive cooperativity. And it's this positive cooperativity of the 4 hemoglobins and the 4 hemes that allows for the sigmoid shape of the oxygen binding curve. In iron deficiency, there's a decreased total hemoglobin, and that results in a decreased oxygen carrying capacity. Table 7-4.1a really shows the various etiologies of iron deficiency. And you can read these as well as I can, but let's go through and talk about some of the prominent clinical stories that come out of this. Obviously, let's talk first about increased blood loss. Remember, the body has no mechanism for eliminating blood other than menstruation in reproductive age women. So anytime we see iron deficiency in a male or in a postmenopausal female, we have to ask ourselves this: that blood must have fallen outside the body, because if the blood had been lost inside the body, it would have been recycled by our macrophages. So now we have to think through clinically, how do you lose blood outside your body and not know it? Well, it's not going to be because you have a lot of nosebleeds. You would know that. It's got to be insensible blood loss, and the commonest place for that is going to be the GI tract. If someone is over 50, the commonest way you have ongoing blood loss from the GI tract is going to be colon cancer. And if that question isn't on your exam, I can say you should write a letter saying, "Dear Sir or Madam, having taken your test, I am unclear why this fundamental and important question was not asked." So if a 60-year-old male presents with fatigue and your CBC shows a microcytic anemia and the ferritin is low, what is the next test you're going to do? And the answer better be colonoscopy. And a postmenopausal female is the exact same story as a male. The second presentation is menorrhagia. Remember that heavy menses can lose so much blood that the female can become iron deficient. This is so common that you're really not going to investigate it. If you have a reproductive age woman that describes very heavy periods and she has fatigue from her microcytic anemia with low ferritin, you're going to put her on iron supplements. If she does not respond to her iron supplements, you can now use that magic word, refractory iron deficiency anemia. And the commonest cause for that is going to be von Willebrand's disease. So put this patient clearly in your mind. A 23-year-old woman comes in complaining of fatigue. CBC shows a microcytic anemia. Serum ferritin is low. After several months of iron therapy, she doesn't respond. You can now investigate her. And the commonest inherited defective coagulation is going to be von Willebrand's disease, and that is a classic first presentation of it. Decreased intake is really common in the very young and the very old. In infants, milk is a very poor source of iron, which is why with your women who just had babies, you're going to try to introduce cereal as rapidly as you can into the diet. In the elderly who are socially isolated, it actually takes a great deal of effort to prepare your food, and so they generally give up. And they live on a very simple diet that's very easy for them to prepare. And sort of the catchphrase that you're going to see in everyday medicine is they refer to this as the tea and toaster, meaning it's very easy to boil water and make a cup of tea, and it's very easy to put a piece of toast in the toaster and eat it. So in your socially isolated elderly, iron deficiency can be from cancer, but it can purely be from a bad diet. Obviously, malabsorption, acid helps with the absorption of iron, and so your patients with achlorhydria or who've had gastric surgery, that can lead to iron deficiency. Remember that iron is absorbed in the small bowel, so you can see it in celiac sprue, and then increased utilization can lead to iron deficiency, and most of your pregnant women are going to be on iron supplements. So now we're back to our investigation. It's the same table we've seen at the beginning discussing labs, but here, of course, we're talking about iron deficiency. So in our classic iron deficiency, we have a low serum iron and a high transferrin, so that's going to give us a low saturation of less than 15%. We would expect to see a low ferritin, and if we looked in the bone marrow, there would be no stainable iron. And the stain for iron is Prussian blue. When we look at the peripheral blood smear in iron deficiency, we have small cells, and that low MCV is called microcytic, micro-small cytose cell. And remember, we have a decrease in hemoglobin synthesis, so the cells tend to be pale, so they're hypo, low, chromia color. And when we look at that smear, we can see they also have really marked anisocytosis, so that's variability in cell size, and that would correlate to an increased RDW on the CBC. So remember that iron deficiency is not a disease. It's not a diagnosis. It's a state in which you either haven't eaten enough iron, or you can't absorb it, or you're losing red blood cells. So you don't have a diagnosis of iron deficiency and then treat the patient. You must always explain why they're iron deficient. When you do treat, and your treatment is successful, classically with oral iron supplements, if it's a dietary deficiency or blood loss, we should start to see the reticulocytosis in 5 to 7 days. Anemia of chronic disease is probably the most common cause of anemia in hospitalized patients. It occurs in the setting of chronic infection, such as active tuberculosis, in diseases with chronic inflammation, rheumatoid arthritis and lupus erythematosus come to mind, and malignancy. It's usually a mild anemia, and it's quite uncommon for the hemoglobin to be less than 9 milligrams per deciliter. Anemia of chronic disease is usually normocytic and starts in the normocytic range, but it'll always be at the low end of the range, so you're going to see it typically 75 to 85 femtoliters. And if we look at our algorithm, you'll see that ACD is both listed in the microcytic and normocytic side. Anemia of chronic disease is due to the effects of inflammatory cytokines. We see that IL-1 and INF suppress the response of bone marrow erythroblasts to erythropoietin. As well, IL-6 induces an acute phase response in the liver. Part of that acute phase response is increased hepcidin production, which suppresses the iron absorption from the gut and blocks iron release from storage site due to its effect on ferroportin. Laboratory testing in anemia of chronic disease can be a problem because ferritin is an acute phase reactant that can increase as much as 3 to 4 times in inflammatory states. So while a low serum ferritin is diagnostic of iron deficiency, a normal level really isn't terribly reliable. Similarly, transferrin production is decreased in anemia of chronic disease, so it's difficult to use iron saturation levels as a definitive test. Ultimately, if the diagnosis is difficult to make, one has to do a bone marrow aspiration and stain the marrow for the presence or absence of iron. If no iron is present, that's iron deficiency. If any iron is present, that's anemia of chronic disease. And obviously the stain for iron is Prussian blue. Table 7-4.2 is very familiar to us now, and now we can see that in anemia of chronic disease, it's hard to use percent saturation. Serum ferritin is diagnostic of iron deficiency if it's low, but a normal ferritin can be tricky, so we have to understand that we might have to do bone marrow biopsy to resolve the differential. Sideroblastic anemias are a complex group of disorders that involve the abnormalities of heme synthesis. And when we look at a list, they include congenital diseases such as deficiency of ALA synthase, toxic exposures, and we can see that lead and isoniazid are going to be very important entities to see this through, rare cases of niacin deficiency, and we can even see it in clonal disorders such as the myelodysplastic syndrome disease of refractory anemia with ring sideroblasts. If we come down and look at figure 7-4.3a, we can see this metabolic pathway of heme synthesis. And I have to tell you in all candor, I've learned this 5 times perfectly in my life, and I have completely forgotten it 5 times as well. I think this is a very difficult metabolic pathway to keep and use, so I honor you if you want to do it, but I don't think it's going to harm your score if you don't. That said, there are some points we should take out of it, because we're not going to come across them elsewhere in our studies. The first is our discussion of the porphyrias. I think there are 2 porphyrias of which you should be aware. The first is going to be here in the middle, acute intermittent porphyria, AIP. Remember that in AIP, we're going to have an absence of our porphobilinogen deaminase, and therefore we're going to see an increase in porphobilinogen. When we take a look at how our patient looks, this is a disease that is fundamentally neuropathic. So when we talk about nerves as a general heading, when I say nerves, you should be thinking CNS, central nervous system, PNS, peripheral nervous system, ANS, autonomic nervous system. And that's a useful way of thinking through now our symptoms of AIP, because the CNS is going to give us mental alterations. Many people feel King George III of American Revolution fame had AIP in the madness of King George. The PNS, no surprise, is going to give us paresthesias and loss of sensation, but the critical one is ANS, because what we see in the ANS is abdominal pain. So one of the great challenges of rare diseases that are going to fool you in life is when patients present with severe abdominal pain that for all the world looks like surgical pain, and it's actually an expression of their AIP. The other very interesting fact about AIP is that they have red urine when it's exposed to light. And I must confess I've waited all my life to see that. It's on the bucket list for most doctors, but this is a rare disease and few of us get a chance to see it. The other porphyria that one should know about is porphyria cutanea tarda. This is a disease in which we lack our uroporphinogen decarboxylase, but it's really a very simple disease clinically because the buildup of the precursors in the skin is problematic in sunlight because sunlight makes them fluoresce, and that fluorescence gives them blistering. So it's a pretty distinctive history of classically a child going out into sunlight and getting blistering skin is a distinctive enough story that you're going to be able to recognize rare things. Now, we're going to be talking about lead poisoning, so let's just finish up with our figure here and include lead as part of the discussion. You notice that lead actually affects 2 of the enzymes in the cycle. It denatures delta-aminolevulinic acid dehydratase, and it also denatures ferrochelatase. And remember, the universal rules of enzyme deficiencies means that we have a buildup of the precursors. So if I denature my delta-ALA dehydratase, then what I'm going to see is an elevation of delta-aminolevulinic acid, delta-ALA. Similarly, if I denature ferrochelatase, I'm going to see an elevation of protoporphyrin. And that's going to form the basis of our diagnosis as we come through lead poisoning. Our general screening test is just to do a serum lead level, but our most sensitive and specific test is going to measure an increase in protoporphyrin. So let's use lead poisoning as our model disease for the sideroblastic anemias. Lead poisoning is in adults found in occupational settings such as smelters and battery factory. But by far away the most common group you're going to see is in children. And in children the most common exposure is in lead paint. Well, lead paint was banned as a paint additive in 1978. So the only way that children are going to be exposed to lead paint is by eating it, and that's going to be present in an old house. So where houses older than 1978, much more common on the East Coast where that is present. So traditionally, when one writes a question stem on this, knowing the geographic location of the child is going to be very helpful in understanding the disease that they have. And this isn't just an everyday made-up problem. In my very affluent town in New England where I practiced my life, we used to screen every child on entry to grade 1 for lead poisoning. And 5 to 10% of our children had elevated lead levels. So this is a very important occupational, behavioral, and societal problem along the East Coast, and something that if you practice there, you'll see too. Well, there's no really specific finding to let you recognize lead. Remember that lead is a neurotoxin, and so we get cognition, but it's not a specific cognitive loss. Like all anemias, of course, you can present with fatigue, but it's got to be a pretty severe anemia to get that. But the kinds of things you're going to see in your children are going to be things like learning disabilities, behavioral problems. Remember, it affects the autonomic nervous system, so you can have abdominal pain, and you can even have headache. So it's got to be a disease you keep in the back of your mind and screen for with some regularity, because there's no specific clinical clue. If a person is exposed to a great amount of lead, on physical exam you can sometimes see a lead line along the gums, but this has got to be a pretty high level of toxicity. So remember, mechanism of disease, it's an interruption of porphyrin metabolism and denaturation of two enzymes, delta-ALA dehydratase and ferrochelatase, and a buildup there of our free erythrocyte protoporphyrin. The other key fact that we have to know about is in the peripheral blood smear. If we look at figure 7-4.3b, we see the classic peripheral blood smear finding of lead poisoning. This is basophilic stippling. If we look at the red cell in the dead center of the smear, we see these small blue deposits, which are characteristic finding for all of our sideroblastic anemias and therefore also for lead. Clinical suspicion of lead, the screening test you're going to do is serum lead level, but your most sensitive test is going to be your protoporphyrin level. Well, lead poisoning is a significant public health problem because it's an insult to the infant brain. It can occur at very low levels of lead and really isn't easily reversed. So you're going to see this as a common screening test if you do any kind of pediatrics in your practice. And obviously you have to get the child away from the environment where there's an exposure. In settings of acute poisoning, you can chelate with succimer, but this is not terribly useful in the chronic setting. Beta thalassemia is a disease with quantitative decrease in globulin synthesis. There are over 100 different causative mutations described, and no surprise then that there's a wide spectrum of clinical severity. This is typically found in Mediterranean ethnicities such as Italians and Greeks, and the actual origin of the term thalassemia comes from thalassa, the Greek root for sea, and in this case, the Mediterranean Sea. Remember that we're going to see two general patterns of symptoms. We're going to either see the homozygous state or the heterozygous state. So the homozygous state, so-called beta thalassemia major or beta thalassemia disease, is going to present as an obvious severe anemia 3 to 5 months postpartum. Compare that to the heterozygous state, so-called beta thalassemia minor or beta thalassemia trait, which is completely asymptomatic. So this is usually going to be an incidental finding in an otherwise perfectly well adult because they're going to have a mild microcytic anemia on their CBC. So it should pose absolutely no problem on a clinical stem, knowing whether we're dealing with thalassemia disease, which has to be a sick little child, versus thalassemia trait, in which we have a perfectly well adult. So when we talk about thalassemia, we're almost always talking about the homozygote or disease state. This is a really severe hemolytic anemia. So much of the child's metabolism goes to trying to create enough red blood cells that it overall makes them small. Overall, they have cachexia. It can be such a severe anemia they get a high output heart failure. They get skeletal deformities because in an attempt to make the red cells, they get such profound erythroid hyperplasia, they literally can widen the medullary space of the hematopoiesis. Almost all of our congenital anemias are associated with skin ulcers for unknown reasons. As we'll see when we do the pathophysiology, there's actually tremendous intramedullary hemolysis with this disease, and the children can often be jaundiced. increased bilirubin is associated with bilirubin gallstones. The severe anemia can cause reactivation of embryologic sites of hematopoiesis, and so we see the extramedullary hematopoiesis expressed as hepatosplenomegaly. The iron overload, both from transfusion and from hepcidin dysregulation, can lead to endocrinopathies, and it's common for the iron to poison multiple endocrine systems, and the children can have diabetes mellitus, hypothyroidism, and a delayed puberty. So remember that the beta thalassemias are mutations that result in beta chain synthesis production. This can go from a complete absence of beta chain synthesis, the so-called B0 mutations, or just reduced synthesis, which are going to give us the B beta positive mutations. The B0 mutations are a stop codon that completely blocks synthesis of the normal globulin, whereas the beta positives are usually splice mutations that leave at least some beta globulin synthesis. The impaired beta globulin synthesis has two mechanisms. Now think this through. Not just one, they don't make enough hemoglobin. There are two. Obvious decreased hemoglobin A synthesis, so you have small hyperchromic red cells with decreased oxygen carrying capacity. That's intuitive. But note there's a second hemolytic function. There's a decreased survival of red cells and red cell precursors because remember, we don't make enough beta globulin. We have unmatched alpha globulin. And that unmatched alpha globulin actually gloms onto the cell membrane and causes ineffective erythropoiesis in the bone marrow and, in the spleen, extravascular hemolysis. This ineffective erythropoiesis also suppresses hepcidin, and that's a second cause of hemochromatosis beyond transfusional needs. So remember, when we say beta thalassemia, there are two mechanisms of anemia: decreased production of hemoglobin and these alpha globulin chains causing ineffective erythropoiesis and extravascular hemolysis. When you see these little kids, they have very low MCVs. They obviously have decreased hemoglobin production, so they have decreased MCHC, and characteristic is elevated hemoglobin A2. There's nothing particularly distinctive about the peripheral blood smear. They tend to have a microcytic hyperchromic smear. When we look at figure 7-4.4a, we can see the classic findings of a thalassemia smear. We see the hypochromic target cells because we have normal amounts of membrane with decreased hemoglobinization, and we see the nucleated cells, of which there are two, and these are normoblasts. Remember, normoblasts are never normal in the smear, and in this case they represent a marrow stress response to the profound anemia. If we were to do a hemoglobin electrophoresis, which we see in figure 7-4.4b, we can see that in the major disease we don't have any hemoglobin A. The child is basically surviving on hemoglobin F and hemoglobin A2. That's very different than beta thalassemia minor seen above, or beta thalassemia trait, in which we have enough hemoglobin A to give normal function, but we do see a mild increase in hemoglobin A2 and F, which form the basis of diagnosis. So what happens to these children with homozygous disease? Well, it's a very severe disease and they die at an early age. Transfusions increase the iron load, and cardiac disease is an important cause of death. Usually you have to do iron chelation to prevent this. Ultimately, without bone marrow transplantation, however, the children only live into their third decade. Alpha thalassemia is a disease in which there's a quantitative decrease in production of the alpha globulin parts of hemoglobin A. It has a clinical spectrum of disease that really depends upon the number of alpha globulin loci that have been deleted from each chromosome. It tends to be predominantly in the ethnicities from Southeast Asia. And the symptoms, as we'll see when we talk about severity of disease, can be completely undetectable to intrauterine death. So the clinical features really depend upon the number of alpha globulin loci deleted. So it's important to recognize that on the chromosome there are 4 loci, and so we can see 4 possibilities. We can lose 1 alpha locus, seen in the top of table 7-4.5, which would be a completely asymptomatic patient with a normal CBC. As a silent carrier, you're only going to recognize these patients when they have a child that is more severely affected. The loss of two loci give us alpha thalassemia trait. This is, again, asymptomatic, but it can be recognized because it has a mild microcytic anemia on the CBC. The loss of three loci gives us a severe anemia that is called hemoglobin H disease. This is very comparable to beta thalassemia disease with the same features: a small child with cachexia, heart failure, the same skeletal muscle deformities, skin ulcers, jaundice, and gallstones. If no alpha-globulin loci are present, this is a fatal condition, and the child dies in utero of a high-output cardiac failure. This is called hydrops vitalis from the marked edema found in both the lungs and in the tissues, characteristic of congestive heart failure. So we think of our beta thals as beta thal trait and beta thal disease, and these compare in alpha thalassemia, where alpha thal trait is the loss of two loci, and alpha thal disease, or hemoglobin H disease, is the loss of three loci. The mechanism of disease in alpha thalassemia is typically a deletion of some number of the alpha globulin genes from 1 to 4. Again, as in the beta thalassemias, the anemia is due to inadequate oxygenation and excess unpaired globulin chains. As with beta thal, the unmatched beta chains form tetramers, and this is what hemoglobin H is. And the effects of hemoglobin H do cause hemolysis and ineffective erythropoiesis, but not as severe as the aggregates of the alpha chain globulins in beta thalassemia. There's no routine test available to diagnose alpha thalassemia. Both alpha thalassemia trait and hemoglobin H present with a microcytic hyperchromic anemia. It really becomes a diagnosis of exclusion. So as we do our differential of microcytic anemias, we have to rule out iron deficiency, anemia of chronic disease, beta thalassemia, and the sideroblastic anemia, of which lead poisoning is our model disease. It's very helpful to recognize it if they have an appropriate ethnicity, typically Southeast Asia, such as Cambodia or Thailand. It's also seen in Africa. It is possible to see the hemoglobin H inclusion body in the RBCs by supravital stains, but this is not a routine test. Figure 7-4.5 now gives us a chance to compare the electrophoresis of alpha thalassemia to what we saw in beta thalassemia. In this case, you'll notice that both alpha thal trait and normal patients have the same proportions of hemoglobin A2F and hemoglobin A. The only difference is quantitative. So we can see that the absolute level of hemoglobin, indicated in purple, is less in trait. Well, children with untreated hemoglobin H disease die at an early age without transfusion. Again, the problem with transfusion is they increase iron load, and cardiac disease is an important cause of death. Iron chelation is usually necessary to help control this problem, but ultimately without bone marrow transplant, survival is only into the third decade. Hemolytic anemias are an important part of our differential of anemias. Again, we come back to our algorithm, which is part of our way of thinking of anemias, and we can see they are part of the spectrum of normocytic anemias with an increased reticulocyte count. They present as both immune and non-immune, and so for the purposes of our discussion, we're going to start in the non-immune side. Hereditary spherocytosis presents with the classic features of a chronic, extravascular hemolytic state. The patient is anemic, and remember the universal symptom of anemia is fatigue. Because it is hemolytic, we have increased production of bilirubin, and during episodes of hemolysis, we're going to see intermittent jaundice. Increased bilirubin production leads to bilirubinate gallstones, and so patients can present with pain from gallstone cholecystitis. As well, the decreased survival of the red cells is predominantly due to their destruction in the spleen, which undergoes hyperplasia, so patients can present with left upper quadrant fullness from splenomegaly. There's a wide spectrum of disease in HS, and severe forms can present at birth with jaundice. Mild forms actually can be quite asymptomatic till they're exposed by some stressor event in adulthood. On examination of these patients, if they're anemic, they'll be pale. If they've had recent hemolysis with increased bilirubin production, they can be jaundiced. Acute cholecystitis typically has the right upper quadrant pain and tenderness, and splenomegaly is present in 3/4 of the affected patients. HS is a hereditary disorder of red cell membrane proteins that results in a chronic hemolytic anemia. Almost all of these proteins are necessary to anchor the cell membrane to the underlying cytoskeleton. The most common defect is in the protein ankyrin, which anchors the membrane to the actin fibrils. Lacking these links, the membranes bleb off, resulting in a spheroid, less deformable shaped red cell that gets trapped and removed in the spleen. The red cell lifespan can drop from a normal 120 days to as little as 10 to 20 days. Investigation starts as always with the CBC. This is anormocytic anemia. Although a spherocyte is small, after all, we're losing membrane all along and is less than 80 femtoliters, the associated hemolysis gives us a reticulocytosis that typically increases the average red cell population MCV into the low normal range. The two populations do result in a larger RDW, and remember this important exam finding, as because we're losing more membrane than hemoglobin, the spherocyte has an elevated MCHC. As with all hemolytic disease, there's a reticulocytosis, and because these cells have less membrane to volume, they are osmotically fragile. When cells are incubated with a hypotonic or hypoosmolar solution, the spherocytes lyse due to their low surface area to volume ratio. On the peripheral smear, you can actually see the spherocytes. Figure 7-5.1a shows possible spherocytes. Here, a spherocyte is defined as a smaller red cell which lacks central pallor, as well as often possible to pick out the reticulocytes, which are a larger cell with a slightly purplish color. The natural history of these patients is highly variable because there's such a broad spectrum of disease, but some clinical points are worth mentioning. Remember that we have discussed earlier that parvo B19 preferentially infects erythroblasts, and when it does this, there's a temporary loss of red cell production. If we think of this as our usual viral infection of about 2 weeks to resolution, then we've lost somewhere around 2 weeks of production. Well, in a normal person with a 120-day lifespan, that would result in probably 10 to 15% of blood loss, which would be unnoticeable. But in HS, with a lifespan of 10 to 20 days, this can be a complete loss of production of red cells for a critical period and can result in a really profound drop in hemoglobin. The obvious treatment is to give them red cell transfusions for the 1 to 2 weeks it takes to resolve the infection. Ultimately, if a patient has chronic anemia that's very symptomatic, there's no particular way to treat the lacking proteins that anchor the membrane, but you can remove the spleen, which is very effective in increasing the longevity of the red cells that are present. Sickle cell anemia is a common disease among African Americans. It is present both as trait and as disease, heterozygote versus homozygote state. Sickle cell trait is asymptomatic except at high altitudes. Sickle cell disease, by comparison, presents at a very early age in childhood, typically at 4 to 5 months of age, after the protective effects of the fetal-derived hemoglobin F are lost. The first presentation is usually a vaso-occlusive crisis, most commonly bone pain. In the first year or so of life, this tends to be in the hands with inflammation and swelling of the fingers, so-called dactylitis. But in later childhood, this vaso-occlusive crisis will shift to the long bones. Other vaso-occlusive crises include splenic sequestration, acute chest syndrome, stroke, acute abdominal pain, priapism, and papillary necrosis of the kidney. On examination, there really aren't any specific findings, just the usual for a chronic hemolytic anemia. So that would include pallor from the decreased hemoglobin, intermittent jaundice from the bilirubin production of the hemolysis, splenomegaly in childhood until the autoinfarction eliminates the spleen, cholecystitis from pigment gallstones, delayed adolescence from the metabolic stress, and leg ulcers seen in most hemoglobin diseases. Hemoglobin C is also a beta chain mutation. The difference is that in hemoglobin C, the beta chain substitution does not give a neutral tail that allows for polymerization. So patients with hemoglobin C disease do not experience sickling events. And the disease is really one of mild anemia with mild hemolysis and some splenomegaly, but otherwise a normal life. So it's the polymerization and the vaso-occlusive phenomenon that make sickle cell disease so severe. It is not due to the degree of anemia. Sickle cell disease is an autosomal disease caused by a missense mutation in the 6th codon of the HBB gene on chromosome 11. It is a GAG to GTG substitution. This mutation results in a valine amino acid substituting for glutamic acid on the 6th amino acid of the beta globulin of hemoglobin. This results in a protein tail in the beta globulin that goes from negatively charged to neutral, which now allows the beta globulins to polymerize anytime there's a decrease in oxygenation. Polymerization leads to tactoid formation that damages the cell membrane and causes expression of surface protein that binds the red cell to endothelial cells. This leads to hemolysis and microagglutination, and that microagglutination is actually occlusive and leads to organ infarction. Sinusoids, typical in the spleen and bone marrow, have naturally lower oxygen levels and therefore are common sites of infarction. The spleen autoinfarcts and is basically non-functional by early adolescence. One can recognize the loss of the spleen by the presence of Howell-Jolly bodies, which are nuclear remnants, in the peripheral blood smear. Figure 7-5.2a is a very good way of thinking about the red cells of hemoglobin S. On the left side, we can see normal red cells flowing across a division. But with a decreased oxygen state common in sinusoids, we can see this polymerization leading to an alteration of the red cell membrane and the surface protein that makes the red cells sticky to the endothelial cells, causing microocclusions in the small vessels. And those microocclusions are the fundamental basis of all of the problems in sickle cell. Diagnosis of sickle disease is done in two different ways. The screening test is typically the SickleDex test, in which hemoglobin is exposed to a reducing substance which causes it to become turbid in the solution. The definitive test is hemoglobin electrophoresis, and this is illustrated in figure 7-5.2b. At the top we see sickle cell trait, so half of our hemoglobin A is present and half is hemoglobin S. That's in quite marked distinction from the sickle cell disease seen in the lower panel, where there is no hemoglobin A, but rather most of the hemoglobin is hemoglobin S. On the peripheral blood smear, sickle cell disease has very characteristic finding. Figure 7-5.2c shows the very classic sickle shape of the affected red blood cells. Remember as well that autosplenectomy is very common, and this can be recognized by the presence of Howell-Jolly bodies. Figure 7-5.2d shows a very nice example of a Howell-Jolly body in the center of the picture. This blue dot represents a DNA nuclear fragment which should be plucked out by a normal spleen. So the presence of this fragment says there is no significant splenic function. Investigation of the bone pain can be quite clinically challenging because it can be difficult to differentiate a bony infarct from osteomyelitis. As well, remember that sickle patients are prone to ischemic damage to the femoral head giving vascular necrosis, and hip pain can require imaging to identify the vascular necrosis. We see in the right column a reminder that the spleen is an important immune organ against encapsulated organisms, so that we can see in the membrane here which of the bacteria that have capsules. And obviously the key bacteria here are strep pneumonia, Haemophilus influenza type B, and Salmonella. The natural history of sickle cell is still disappointingly problematic. The average life expectancy of a sickle disease patient is now still only in the 40s. Childhood mortality has really improved with the use of the vaccination for the encapsulated organisms. The major risk now in childhood death is acute chest syndrome, in which we get microvascular occlusive disease in the lungs. Since the treatment is so improved in childhood, chronic complications are starting to appear, and the commonest one and most difficult to treat is pulmonary hypertension. Sickle disease has some quite unique complications. Salmonella osteomyelitis is well described and not uncommon. Remember as well, this is a severe hemolytic disease, so the patients are vulnerable to aplastic crisis from parvovirus B19 infection. Microocclusive disease can cause infarction of the femoral head with its end artery blood supply, leading to avascular necrosis. All chronic hemolytic diseases cause increased production of bilirubin, and patients get pigment gallstone cholelithiasis. And then as well, of course, the lack of spleen makes the patients vulnerable to infection by encapsulated organisms. Treatment has become quite extensive, and longevity of the patient really reflects the intensity of the clinical involvement. Most patients are placed on prophylactic penicillin G until age 5. Red cell transfusion is used in support of the anemia. Hydroxyurea increases hemoglobin F levels and is helpful. The ongoing hemolysis puts quite a metabolic demand on the bone marrow, and so folate supplements are necessary. And then always and ever ischemia results in pain, and the patients require medication for pain control. G6PD deficiency is the commonest enzyme deficiency of red cells. It is a disease really that first presents episodically, and the patient may be entirely asymptomatic until they're exposed to some oxidative stress, such as a viral infection or a medication. Symptoms start typically 24 to 72 hours after exposure, and it can be hematuria from an intravascular hemolysis, weakness, tachycardia, and jaundice if the hemolysis is severe enough. On examination, really there's little to find unless the hemolysis is severe and ongoing. And again, the features of chronic hemolysis are the same for any disease: splenomegaly, jaundice, cholecystitis causing right upper quadrant pain from pigment gallstones, and leg ulcers. G6PD deficiency results from abnormalities in the hexose monophosphate shunt because of a decreased production of reduced glutathione. The lack of reduced glutathione reduces the red cell's ability to protect themselves from oxidative stresses. Most commonly, these are infections in which free radicals are produced by white blood cells. Other important initiators include food in the Mediterranean variant, and this is favibine, and drugs, especially antimalarials and sulfas. In terms of examsmanship, a favorite question is to have someone go on a medical mission to a malaria endemic patient. This classically should be an African American because they have much higher incidence of G6PD, and then have the patient develop jaundice on their antimalarial medications. So the lack of reduced glutathione and high levels of oxidants cause denaturation of the globin chains, which form membrane brown precipitates, which can be recognized by supravital stains and are called Heinz bodies. Heinz bodies damage the red cell membrane, causing intravascular hemolysis. As well, in the spleen, the Heinz body inclusions can be plucked out by the macrophages, leaving the characteristic bite cells of the red blood cell. Figure 7-5.3a shows us this metabolic pathway. You can see starting with glucose, we're in the glycolysis pathway, and G6PD to the ribulose 5-phosphate generates NADPH with the presence of glucose 6-phosphate dehydrogenase. NADPH is necessary to keep glutathione in the reduced state, and it's reduced glutathione that breaks down peroxide and prevents the breakdown of the peroxide into free radicals. So G6PD deficiency is the most common inherited enzyme deficiency in humans. It's typically X-linked recessive, and clinically there are two variants. G6PD-A is found in 10% of African Americans. G6PD Mediterranean is found in people of middle Eastern ancestry. Again, once the diagnosis is suggested, the definitive diagnosis can be made by quantitative analysis of G6PD activity. The CBC will be normal because the attacks tend to be intermittent, but during an acute attack, we'll see the classic findings of intravascular hemolysis, such as hemoglobinemia, hemoglobinuria, decreased haptoglobin, unconjugated hyperbilirubinemia, anemia, and over time, reticulocytosis. The peripheral blood smear is going to show the bite cells from the action of the spleen on the membrane protein precipitates and hind bodies using special staining. Figure 7-5.3b shows the hind bodies, which are the small red dots touching the membrane of the red blood cell. Figure 7-5.3 shows a high-powered illustration of the hind bodies in the top image, and then the illustration of a bite cell in the lower frame. G6PD deficiency tends to be a benign self-limited disease. The hemolysis doesn't get terribly severe because G6PD tends to be very active in young red blood cells, and so the one-time exposure affects mostly the old cells, which are replaced by the hemolytic response of reticulocytes. Pyruvate kinase deficiency is the second commonest enzyme deficiency of red cells. The disease presents shortly after birth, if it is severe, with anemia and jaundice that might actually require blood exchange transfusion. It is a hereditary disease, so the patient's family history should be consistent with autosomal recessive inheritance. Milder disease may become symptomatic during times of physiologic stress, and examples include viral disorders in pregnancy. Patients show the usual findings of congenital hemolytic anemias, failure to thrive, skeletal abnormalities from expanded bone marrow medulla, splenomegaly, gallstones, and leg ulcers. The mechanism of disease starts with the fact that red blood cells lack mitochondria, and so they're completely dependent on the glycolytic pathway to generate ATP, which is required to maintain the red cell sodium-potassium ion pump. Deficiency of the pyruvate kinase creates a metabolic block with an increase in the upstream metabolic process. If we take a look at figure 7-5.4, we can see why this disease tends to be less severe than one would expect from the degree of anemia. We see that the absence of pyruvate kinase causes a block in the glycolytic pathway. This then causes a backup of precursors, resulting in an increase of 2,3-DPG. Above this, we see the effect of the increased 2,3-DPG is a right shift of the oxygen binding curve, which offsets the degree of anemia by allowing for easier unloading of the oxygen in the tissue. If this is suspected in a young child, one would see initially on the CBC a normocytic anemia with reticulocytosis, but ultimately the specific diagnosis requires a pyruvate kinase enzyme assay. This should be associated with elevated glycolysis intermediates. The natural history is highly variable because there's such a wide spectrum of different mutations and different diseases. Severe forms are mostly symptomatic during early childhood, and again, treatment can be supportive red cell transfusions. Paroxysmal nocturnal hemoglobinuria is a rare disease. It is a disease that is quite unique because it's the only hemolytic anemia with an acquired genetic defect. It has three major presentations. It can present with intravascular hemolysis. This is recognized by the presence of hemoglobinuria, usually on the first morning void. And it's this finding that gives the disease its name, because it tends to be intermittent, hence paroxysmal. It tends to occur because of the mild acidosis during sleep, so it's nocturnal, and it presents with darkly red-colored urine, hemoglobinuria, on the first morning void. A second presentation is thrombosis, and is actually commoner than the intravascular hemolysis. 40% of the patients will have an unexpected thrombosis, and especially in uncommon veins, such as the hepatic, portal, or cerebral veins. PNH can also be associated with aplastic anemia, which would present with one of the dominant cell lines of a pancytopenia. So anemia presents with fatigue, thrombocytopenia is going to present with bleeding, and neutropenia would present with a bacterial infection. The acquired genetic defect in PNH is a loss of cell membrane regulatory proteins due to a gene defect in the phosphatidylglycan complementation class A gene, so-called PIGA. The PNH blood cells are deficient in the GPI-linked proteins CD55 and CD59 that are necessary to clear complement from the red cell membrane. The inability to clear complement makes the red cells susceptible to the C5b-C9 MAC attack hemolysis. The mechanism of thrombosis isn't well understood, but it's also related to this abnormal complement activation. PNH is mostly diagnosed by flow cytometry now. Note that the deficiencies of CD55 and CD59 are integral to the disease, and those are the red cell proteins looked for in the flow cytometry. In Figure 7-5.5, we see a good example of the flow cytometry of PNH. Remember that in flow cytometry, the X and Y lines are used to indicate positive and negative. So everything above or to the right of the lines is present, and everything below or to the left of the lines is absent. So if we take a look at the control, which is a normal patient, the black dots, we can see the presence of CD59 and CD55. Our patient with PNH, marked by red dots, are below and to the left line, meaning they have neither. Well, PNH is actually a moderately severe disease in which thrombosis is the leading cause of death. 5 to 10% of the patients develop acute myeloid leukemia. Mechanical trauma anemia refer to the mechanical disruption of red cells due to actual physical harm to the membrane. It used to be very common when mechanical heart valves were used, but now with the use of biovalves, this is an uncommon effect. We can now see it in things like foot trauma, in which Army recruits go on long marches with Army boots, and we can see it in marathon runners. It has even been described in bongo drummers due to the beating of their hands on the drum. It may result in a mild hemoglobinuria after the traumatic event, but this is rarely severe enough to cause anemia. Far more important are the microangiopathic edemas. Specifically, this refers to disseminated intravascular coagulation, DIC, thrombotic thrombocytopenic purpura, TTP, and hemolytic uremic syndrome, HUS. In all of these diseases, there's deposition of fibrous strands across the lumens of small vessels, and this applies shearing forces to the red cells, which results in schistocytes, by which we mean cell fragments. Figure 7-5.6a shows the process. In this, we see a normal red blood cell basically cutting itself across a fibrin strand and giving two fragments. These are schistocytes. Over time, these schistocytes will round up into their most efficient shape size, which is a spherocyte. Figure 7-5.6b shows what this looks like in an actual patient. In this, we see the classic spherocyte, a small cell lacking central pallor, and we see the cell fragments from the fibrin stranding, which are good examples of schistocytes. Immunohemolytic anemia is now the preferred name for autoimmune hemolytic anemia. These anemias all share the typical features of chronic extracellular hemolytic anemia. This includes fatigue from the anemia, jaundice from the unconjugated bilirubin, right upper quadrant pain from the acute cholecystitis from pigment gallstones, and splenomegaly from the hyperplasia required for increased phagocytosis of red cells. The immunohemolytic anemias, also known as autoimmune hemolytic anemias, are caused by antibodies binding to the red cells, causing their premature destruction. Usually these are IgG antibodies that are active at body temperature, hence warm. In about half your patients, the etiology will never be discovered. The other 50% can be associated with drugs, connective tissue diseases, especially systemic lupus erythematosus, and malignancy, especially CLL, SLL. Note that in chronic lymphocytic leukemia, small cell lymphocytic lymphoma, hemolytic anemia is seen in about 10% of cases. Other antibodies include IgM antibodies that can be activated at cold temperatures, and these are called cold agglutinins. Most commonly, this causes Raynaud phenomenon because at the acral surfaces, meaning the fingers, the toes, and the tip of the nose, they tend to be cooler in cold weather, and that activates our IgM, which causes agglutination, and that restricted blood flow gives us Raynaud phenomenon. When the patient comes into the warm, we lose the cold temperature activation, and the occlusion resolves. There can be some degree of hemolysis because IgM activates complement, and complement on a red cell leads to its destruction in the spleen. Note that IgM cold agglutinins are associated with mycoplasma pneumonia. Investigation of these diseases, well, the Coombs test is positive. It's an hemolytic anemia, so it's a normocytic anemia with increased reticulocytes. Hemolysis is associated with reticulocytosis and the destruction with unconjugated hyperbilirubinemia, and we'll see two different patterns of disease. In warm antibodies, we see spherocytes, but with cold antibodies, we see agglutination. Figure 7-5.7 shows a really nice example of agglutination. Remember that IgM is a very large pentamer protein, so it can bind together multiple red cells into a clump. And that's exactly what we see in the image. We see these irregular clumps of red cells due to the activated IgM antibodies. Because these are such a heterogeneous group of diseases, there's a wide spectrum of severity. Ultimately, the outcome of the hemolytic anemia depends upon successful treatment of the underlying disease. In the 50% that have no known cause, generally speaking, treatment starts with steroids, and if that is unsuccessful, splenomegaly. Cold immunohemolytic anemia can be treated with rituximab, which is an anti-CD20 antibody. Again, we're starting with what must be in your brain for the rest of your life as a practicing physician, and therefore the right thing to take into the exam, which is our algorithmic approach to the anemias. We're now going to do our non-hemolytic anemias. So we start at the top. Anemia is a decrease in hemoglobin or hematocrit, and the next thing we look at is the cell size, MCV. The normocytic anemias have a cell size of 80 to 100 femtoliters. We then have to decide, is it increased destruction, hemolysis, or decreased production, non-hemolytic, and this is decided by retic count. With a low retic count, we know there's decreased production. We then have to think through, what is the cause of that? Is it due to some intrinsic abnormality of the bone marrow hematopoiesis, or is it something else? If it isn't obvious by clinical history, so for example, we look down in the decreased production side at renal failure, we should be able to recognize that from our elevated creatinine. Similarly, if we know that the patient has a big spleen, a common cause for that might be cirrhosis, then we're not going to really need to do a bone marrow to sort out why the patient might have a normocytic anemia. But if it isn't clear from the clinical picture, then away we go and we do the bone marrow to say, what is the status of marrow production? Aplastic anemia is a classic example of failure of hematopoiesis at the bone marrow level. It classically presents as a pancytopenia. So remember, when we talk about our myeloid cell lines, we're talking about red cells, neutrophils, and platelets. A deficiency of red cells, anemia, presents with fatigue. A deficiency of platelets, thrombocytopenia, presents with abnormal bleeding. And deficiency of neutrophils, neutropenia, is going to present with a bacterial infection. Now, pancytopenia you would think would imply all three of those down. But in fact, in clinical convention, any two down is enough to call the patient pancytopenic. The mechanism of aplastic anemia is usually characterized and ascribed to a failure of hematopoietic stem cells. It's usually thought to be autoimmune if it's idiopathic, but there are secondary causes such as drugs, marrow irradiation, and chemotherapy. Congenital form is Fanconi's anemia, which you recall is a disease with multiple abnormalities including short stature, absent radii, and heart defects. This is a disease that's going to present with pancytopenia. Peripheral blood smear will show no blasts, and therefore the patient will have a bone marrow biopsy. And this is a really good picture of it here in figure 7-6.1a, in which all we see, the pink structures, are our bony trabeculae of the bone marrow, and after that what we basically see is just fat. This is called an empty marrow. Well, if you're not making any hematopoietic cells at all, not surprising that this is considered a medical emergency. And without treatment, life expectancy really is down to months. Treatment includes immunosuppressive agents like cyclosporin, steroids, anti-thymocyte globulin. The patient is given hematopoietic growth factors such as EPO, TPO, and granulocyte colony stimulating factor. Red cells are supported by transfusion, and if all else fails, the patient requires bone marrow transplantation. Anemia renal failure is an important discussion because of its clear illustration of the physiology of red cell production. In America now, this is probably the commonest presenting symptom of chronic renal failure. The anemia is caused by a lack of production of erythropoietin, called EPO. Remember, normally EPO is produced by specialized cell in the peritubular capillaries of the kidney. In the unstimulated state, there is suppression of hypoxia-inducible factor. But when hypoxia is present, it prevents the proteasome degradation of hypoxia-inducible factor, HIF. High levels of HIF upregulate production of EPO in these specialized cells. The EPO goes to the bone marrow where it induces hyperplasia of erythrocyte precursor cells and decreases their apoptosis. In chronic kidney disease, destruction of the tubular interstitium causes loss of EPO synthesis. The degree of anemia parallels the level of kidney disease. And remember, as well, as we get into more severe forms of renal failure, uremia also has abnormal platelet function, and that's associated with bleeding and decreased red cell survival as well. So this is a good time to stop and remind ourselves how hematologic diseases present. And as always, look how we divide this, the top bar being myeloid, and then the bottom two rows being lymphoid. So when we talk about hematologic diseases, as always, you divide it into lymphoid and myeloid. Myeloid diseases present as a cytopenia. So red cell deficiency anemia presents with fatigue. Neutrophil deficiency, neutropenia, presents with bacterial infections, and those are associated with fevers. Platelet deficiencies, thrombocytopenia, present with bleeding in the skin, which are going to be our petechiae, or bleeding from our mucosal surfaces, which are going to be from the nose, epistaxis, in the female from the endometrium, MMR, metromenorrhagia, from the gums, particularly with brushing of teeth, or from the GI tract, which could be hematemesis from the stomach, or bleeding from the colon. Remember, bleeding from the colon can be bright red blood, hematochezia, or from higher in the tract and altered by the bacteria, melena. But note here at the beginning of that hemorrhage list, the dread complication of thrombocytopenia is bleeding into the head, intracranial hemorrhage, and this is life-threatening. Compare in this table the myeloid with our 3 cell lines with our lymphoid. Note that by far and away the commonest presentation of lymphoid diseases is lymphadenopathy. Note also B symptoms, which are fever, night sweats, and weight loss. So keeping in mind as we go through our hematologic diseases, how patients present is part of every doctor's understanding of disease. Myelophthisis is a disease of marrow failure when the marrow is replaced by space-occupying lesions. In the modern Western world, this is typically going to be metastatic diseases, but any infiltrative disease like granulomas of TB can cause it as well. In the myeloproliferative diseases, fibrosis of the marrow can also have the same effect. Patients present with pancytopenia, and there's a characteristic peripheral smear finding of leukoerythroblastic picture. This is seen in figure 7-6.3 in the column. Dead center, we have a small, dark red cell nucleus of a normoblast. As well, we see immature granulocytes, such as the myelocyte and metamyelocyte seen in our picture. The finding of a leukoerythroblastic smear is an indication for bone marrow, and bone marrow biopsy is a very effective tool for diagnosing metastases and fibrosis. Megaloblastic anemias all have impairment of DNA synthesis that leads to ineffective erythropoiesis. Remember what ineffective erythropoiesis means. It means that we have increased hematopoiesis that does not successfully get to maturation and release into the peripheral blood. So this means we have hypercellular bone marrow, but peripheral cytopenias. Megaloblastic anemias all have distinctive morphologic abnormalities with very large red cells, defined as greater than 100 femtoliters, and abnormalities in the other cell lines as well. They're most commonly associated with vitamin B12 and folate deficiency, which are necessary for the synthesis of thymidine. Obviously, chemotherapeutic drugs, which inhibit folate metabolism or DNA synthesis, can lead to the same picture. Methotrexate is a good example of this. It can be inherited. Erotic aciduria is an autosomal recessive disease with a defect in pyrimidine synthesis due to a lack of uridine monophosphate synthase. Remember as well that macrocytosis, greater than 100 femtoliter MCV, is not only associated with abnormalities of DNA synthesis, but also with some diseases of the red cell membrane, such as alcoholism, chronic liver disease, and hypothyroidism. Just as an aside, note that reticulocytes are larger than normal red cells and typically have an MCV between 105 and 120 femtoliters. Their presence certainly raises the MCV, but classically not into the macrocytic range, but we include it here in the differential as a reminder that they are larger cells. Vitamin B12 deficiency presents as anemia, which is fatigue, but also with neurologic findings. So remember, this can be CNS symptoms, which can be a broad spectrum of changes from personality change all the way to frank psychosis. It can present as a peripheral neuropathy, which can be a paresthesia, such as burning or tingling, as well as loss of function, such as numbness. The spinal tract of the spinal cord can be affected, so-called subacute combined degeneration, and this can give ataxia or unsteady gait. On physical exam, your patient is going to have the pallor of anemia. Remember that they have shiny red tongues, which is seen in many vitamin and mineral deficiencies, and as well they're going to have the neurologic findings. Poor mental function and loss of proprioception are present, and this will be a positive Romberg sign, but by far and away the easiest test is loss of proprioception by showing loss of perception of vibration. So vitamin B12 deficiency is manifested because B12 is a cofactor of two enzymes, methionine synthase and L-methylmalonic-CoA mutase. The conversion of homocysteine to methionine is important for the production of methionine, which is used in many methylation processes. But it's also important in the demethylation of folate, the lack of which leads to the so-called folate trap. The lack of thymidine means there's a block to DNA synthesis. So decrease in vitamin B12, cobalamin, results in an effective deficiency of usable folate. Note as well, inability to synthesize methionine also results in a buildup of homocysteine, which is an independent risk factor for atherosclerosis. So figure 7-7.1a is a good diagram to think of the metabolic pathway of B12 and folate metabolism. Note that circulating folate is in the methyl tetrahydrofolate form, and to be usable, it must drop the methyl group off to B12. The tetrahydrofolate now can be used by thymidylate synthase to convert our uridine to our thymidine, which can be used in DNA metabolism. The methylated B12 now can donate that methyl group to homocysteine in the creation of methionine. Well, that certainly explains the hematopoietic abnormalities. What's less certain is an explanation of the neurologic abnormalities of B12 metabolism. The general discussion and general consensus is that the conversion of L-methylmalonyl-CoA to succinyl-CoA provides a key component of the tricarboxylic acid cycle, and this is really important for the production of energy from fats and proteins. It's felt that a block in this step results in a buildup of methylmalonic acid, and this can be associated with abnormal myelin synthesis, which may partially explain the neurologic abnormalities. As we look at figure 7-7.1b, we see now a discussion of this TCA cycle function. And when we see the lack of B12, blocks the conversion of methylmalonyl-CoA to succinyl-CoA, we appreciate that this block leads to the buildup of the methylmalonic acid, which is the most sensitive test in diagnosing B12 deficiency. Vitamin B12 metabolism is quite complex. It is the only water-soluble vitamin that's stored in the body, and a normal person has 3 to 5 years stores in their liver. The best way to think about it is to draw this picture that we see in Figure 7-7.1c to enumerate the steps of the function. We start by where we first get vitamin B12. Vitamin B12 is only available in meat. It is chewed and goes down to the stomach, where vitamin B12 must be extracted from the meat by the presence of pepsin. Vitamin B12 now must be protected from the acidity of the stomach by binding with haptocorin, or so-called R factor, which is made in the salivary glands and joins with the B12 in the stomach. The protected B12 bound to our R factor now travels out of the acid and acidic environment, and in the now neutral to alkaline environment of the duodenum, it now undergoes breakdown by proteases. This releases the B12, which can now bind to the intrinsic factor produced by the parietal cells. Our B12 bound to intrinsic factor travels down to the terminal ileum, where there are receptors, and it is absorbed. So let's take a look at those steps and imagine how patients can get into pathologic difficulties along the way. Obviously, if B12 is only found in meat, people that don't eat meat can be deficient in B12, and our classic example here are vegans. Remember that we require R factor, also called haptocorin, to protect the B12 in the acid environment of the stomach. Sjogren's disease, an autoimmune disease of exocrine glands, can damage the glands so severely that there's inadequate R factor. And in fact, about 3% of your Sjogren's patients are going to be B12 deficient. Remember that the acid environment is necessary for our pepsin activation, and that can be deficient in atrophic gastritis and post-gastrectomy surgery. The intrinsic factor that's necessary for the uptake in the terminal ileum is produced in the parietal cell, and parietal cells specifically are lost in pernicious anemia. We need the proteases from the pancreas to cleave the R factor from the B12, and these are deficient in children in cystic fibrosis and in adults in chronic pancreatitis. Loss of the terminal ileum in Crohn's disease can result in B12 deficiencies because there are inadequate intrinsic factor receptors. And then rarely there are other conditions. Probably the most famous for medical students is the presence of a tapeworm, Diphyllobothrium latum, and these can achieve lengths of 20 feet. And they preferentially compete for the B12 such that all of the B12 goes to the tapeworm, leaving the patient deficient. This is a pretty uncommon finding, but the one place you will find it is in the northern central states like Minnesota, where the Finnish culture, instead of pickling herring, which is a saltwater fish, actually pickle the white fish of the lakes, and pickling does not kill the eggs, and so this has been described in that culture, in that geography. So when your patient presents with anemia, it's going to be a macrocytic anemia, and in fact, remember, this is ineffective hematopoiesis of all the cell lines, so they might also have low platelets and neutropenia. The peripheral blood smear is going to show large macroovalocytes, and the discordance of maturation can give hypersegmented neutrophils, which is defined as having 5 or more lobes. There's ineffective erythropoiesis and a lot of turnover in the marrow so that we can see an elevated LDH. Basic screening test is going to be just to measure the serum B12 level, but obviously the most sensitive and specific test is to show an elevated methylmalonic acid. Note that, of course, methylmalonic acid would not be elevated in folate deficiency. Remember that we need B12 to methylate homocysteine to methionine, so if there's no B12, we get a buildup of homocysteine, and this is a risk factor for atherosclerosis. And then our commonest disease for B12 is going to be in pernicious anemia, and in that disease we're going to see anti-intrinsic factor and anti-parietal cell antibodies. If patient investigation gets as far as bone marrow examination, there will be megaloblastic changes. with giant metamyelocytes. Remember, this is a hypercellular process because we have increased production, but few of the cells make it properly to maturation for apoptosis, and so we have decreased release. Because pernicious anemia is the commonest cause in our population, typically patients go to gastric endoscopy to diagnose atrophic gastritis and intestinal metaplasia and to rule out the associated neoplasm. Figure 7-7.1d shows a hypersegmented neutrophil in megaloblastic anemia. Remember that the definition of hypersegmented is 5 or more lobes. The box insert shows a clinical application that no longer exists. The Schilling test was very commonly used in medicine, perhaps as much as 10 or 15 years ago, but in fact there's no accessibility to the cobalt tag anymore. So we don't see it in clinical medicine, but it's a very useful thought experiment to test one's understanding of the steps of B12 metabolism and the diseases that affects it. The Schilling test works like this. First, the patient is injected with regular vitamin B12, and this saturates the liver cobalamin receptor. The patient is then given a dose of oral reactive vitamin B12. Classically, we used to use cobalt 57. Now, in a normal person, that cobalt 57 should be absorbed and more than 10% of it excreted in the urine over the next 24 hours. So if the excretion was low, the test would now be repeated with intrinsic factor. If this corrected the problem, shown by more than 10% activity, then clearly the problem was a deficiency of intrinsic factor, or in other words, pernicious anemia. If intrinsic factor does not correct the problem, then the problem has to be something to do with intestinal malabsorption. The test is then repeated with pancreatic enzymes. If that corrected the problem, the diagnosis is now pancreatitis. If that doesn't correct it, then we're left with other causes of malabsorption, such as Crohn's disease, or bacterial overgrowth, or Diphyllobothrium latum. Table 7-7.1 summarizes the Schilling test. And in this we can see a normal tagged B12 should have greater than 10% excretion in the urine over 24 hours. If just giving B12 corrects the problem, that's a good example of dietary deficiency. If intrinsic factor is required to correct the problem, that's a classic example of pernicious anemia. If pancreatic enzymes are required, then the diagnosis must be pancreatic insufficiency, which would be cystic fibrosis in children and chronic pancreatitis in adults. Pernicious anemia is fatal without treatment, hence its name, pernicious, ongoing. But with parenteral B12, obviously, it completely corrects the problem, and so that sad page of medical history no longer is seen. In Figure 7-7.1e, we see a rare example of a bone marrow biopsy in B12. And we can see that we don't have a normal to compare it to, but with experience one recognizes that all of these nuclei are very large for size. And this is called the nuclear cytoplasmic discordance of this disease, because the cytoplasm can mature at a normal rate, but the lack of the thymidine means we have dissociation of the nuclear maturation, and we get very large nuclei by comparison. Folate deficiency is very uncommon in the Western world because most of our foods have mandatory supplements, and this has been true for the past 20 years. It's really now restricted in our culture to alcoholics and others with obvious malnutrition. These patients will often complain of a sore tongue or painful swallowing. They have very thin epithelium. GI complaints such as nausea and abdominal pain and diarrhea may be present. But on examination, there really are no unique physical findings. The sore tongue might be associated with redness, so-called glossitis, and some degree of hyperpigmentation. The pathophysiology is pretty straightforward. Folate is necessary in pyrimidine synthesis of thymidine and in the synthesis of methionine from homocysteine. And we saw that in our previous discussion of vitamin B12 deficiency. If you suspect this in your patient, you can order a serum folate level. But there's a trick here because most of these are going to be seen in alcoholics presenting acutely to the hospital. And if there's any delay in ordering the test, the patient will often be fed before the test is drawn. And folate is water-soluble and absorbed in the proximal bowel, so that if you delay too long in ordering your serum folate, it might have already corrected after the first meal. In this case, you're going to order a red blood cell folate because that actually represents long-term status. Of course, you're always going to order a vitamin B12. Just because you're folate deficient doesn't mean you're also vitamin B12 deficient, and giving folate is not going to correct your B12 problem. Note, as we look at the metabolic pathways, homocysteine will be elevated in both folate and cobalamin deficiency, but methylmalonic acid is only going to be elevated with cobalamin deficiency. Obviously, if your patient's on a normal diet, they must be malabsorption, and that's discussed in our chapter on GI pathology. As with B12, without access to the vitamin, the anemia and other marrow production deficiencies are progressive. Polycythemia refers to an increase in red cell mass. As we discussed earlier in this chapter, we really don't have a routine test to measure red cell mass. And the way we measure it is by drawing whole blood and comparing the volume of red blood cells to the volume of plasma. And we do this both through hematocrit and hemoglobin. The trouble with this is we have to allow for changes in plasma. And obviously dehydration can lead to a relative increase in hematocrit. And therefore this is a relative polycythemia. And you're going to see this frequently in practice. You're going to see patients with vomiting and diarrhea that are going to seem to have a mildly elevated hemoglobin, and when you rehydrate them, it will correct. Relative polycythemia should be contrasted to absolute polycythemia. And this is differentiated between primary disease, which is defined as disease actually in the marrow in the erythrocyte precursors, versus secondary disease, which is due to an increase in erythropoietin. Remember, EPO can be increased two different ways. It can be physiologic from hypoxia or pathologic due to paraneoplastic. So if we come down and look at figure 7-8.0, this is really an excellent way of thinking about the disease. In the first row, we have normal. We can see plasma volume, red cell volume, a normal level of oxygen saturation, and a normal EPO. Let's now move down one bar. We can see that relative polycythemia, we have an apparent increase in our hematocrit because we've shrunk our plasma volume. When we rehydrate this patient, that will correct. If we go down to the third row, secondary disease, we can see now we have a true increase in red cell mass, and we can see that its cause must be related to decreased O2 because we have a decreased saturation. This now becomes secondary physiologic disease, and a common cause would be chronic obstructive pulmonary disease. Compare that to our fourth row, secondary disease from paraneoplastic. In this situation, we can see there's a true increase in red cell mass, but now our oxygen saturation is normal. And then paradoxically, we have elevated EPO. Well, the elevated EPO is coming because it's being produced by the tumor. And the two commonest tumors that do this are renal cell carcinoma and hepatocellular carcinoma. The last row shows us the primary neoplasm of the erythroblast. Again, we see an absolute increase in red cell mass. Normal saturation tells us this is not pulmonary in origin, but now we have a decreased EPO. As we would expect, increased red cell mass should shut down EPO production in the kidney. But the patient still makes red cell because we have a primary abnormality in the erythroblast, so this is a neoplasm, polycythemia vera. Remember how we think about the myeloproliferative diseases. Basically in medicine, we think about the translocation T922 in chronic myelogenous leukemia. So this creates the abnormal protein, BCR-ABL, and that should be compared to our other family of myeloproliferative diseases, polycythemia vera, essential thrombocythemia, and primary myelofibrosis, which are most commonly associated with JAK2. So as we talk about our neoplasms of the myeloid series, we fundamentally divide them into two families, the BCR-ABL positive CML, and then the BCR-ABL negative, usually JAK2 positive mutations of P. vera, essential thrombocythemia, and primary myelofibrosis. Polycythemia vera is a myeloproliferative disease which is a neoplasm of myeloid cells. It really is asymptomatic until late in the disease, in which the patient can develop hyperviscosity. When hematocrit is greater than 60%, there's sludging of the blood flow, and that can lead to hypoxia with headaches, dizziness, and blurry vision. Remember when we went all the way back to the beginning of our chapter and we talked about hematopoiesis, we talked about the myeloid series being divided into two families, the erythroid megakaryocytic family and the granulocytic monocyte family. No surprise then that a percentage of patients with P. vera will also have abnormalities of their platelets, and then these can present with either hemorrhage or thrombosis. One of the curiosities of P. vera is that it can be associated with elevated levels of histamine, which can cause peptic ulcers, or itchiness after bathing in hot water, which causes histamine release from mast cells and basophils. The physical findings on examination basically are plethora, meaning a red face from the elevated hematocrit. These patients can have associated hypertension from pumping the hyperviscous blood, and splenomegaly is seen in about 3/4 of patients. P. vera is usually due to a mutation in the JAK2 domain that permanently turns on cytokine receptors so that progenitor cells, the erythroblasts, are pathologically sensitive to erythropoietin. This usually also affects the megakaryocytic cell line so that P. vera often has thrombocythemia, and these abnormal platelets can be associated with thrombosis and hemorrhage. As well, increased mast cells and basophils cause the histamine-related symptoms, and the diagnosis is based, as one would think, the finding of erythrocytosis or polycythemia, a hypercellular marrow on bone marrow, a JAK2 mutation, splenomegaly, and note, a decreased EPO level and often a normal O2 saturation. As we look over in the right column, we see this important concept. I think it's going to be too soon for testing, but it's important that this is really getting ready medicine for life. So let's just take a moment and make sure we understand this. Myeloproliferative diseases are really fundamentally now thought of as two families, thought of as the BCR-ABL positive and BCR-ABL negative families. So BCR-ABL positive, that's our chronic myelogenous leukemia. The BCR-ABL negative are going to be our P. vera, essential thrombocythemia, and myelofibrosis. So in P. vera, more than 95% are going to be your JAK2 mutations, specifically the V617F mutation. You'll see in many of the older books they talk about how JAK2 is only seen in about 50% of myelofibrosis. But in the past year or two, two new mutations have been identified, MPL and CALR for calretinin, and they, together with other mutations of JAK2, now explain over 90% of essential thrombocythemias and primary myelofibrosis cases. Well, how do patients with polycythemia vera do? It's basically an indolent disease. The major risk are the consequences of hypertension and hyperviscosity, and these can really be managed nicely by phlebotomy. Thrombosis, of course, occurs at the level of the platelet, and that can be managed with aspirin. Over a decade, probably 10% of the patients will progress to myelofibrosis, and a small handful, somewhat less than 5%, go on to acute leukemia. Essential thrombocythemia is a clonal disorder of megakaryocytes, and specifically does not include elevated red cell production because that would then be called polycythemia vera. About half of essential thrombocythemias have a JAK2 mutation, but as we noted, remember, two new mutations, our MPL and our calretinin mutations, have been discovered, and so now these three mutations really account for over 90% of the abnormalities. The major risk in essential thrombocythemia is abnormal platelet function, and that results in hemorrhage or thrombosis. Diagnosis is based on the finding of a platelet count over 500,000. Bone marrow shows megakaryocytic hyperplasia. Classic mutations, JAK2 mutation is the commonest, but two new mutations have been described. And of course, iron deficiency has to be excluded because, for reasons poorly explained, it has associated elevated platelet counts. The greatest risk of essential thrombocythemia is thrombosis, so controlling that with aspirin is important. It's an indolent disease. Peak age of diagnosis is at 50, and most patients have a near normal life expectancy. Myelofibrosis is the third of the BCR-ABL negative myeloproliferative diseases. Myelofibrosis is a clonal, meaning neoplastic disorder of hematopoietic progenitor cells in which the dominant abnormality now is fibrotic replacement of the bone marrow. This is typically ascribed to an overproduction of TGF-beta and PDGF, platelet-derived growth factor, from the megakaryocytes. 90% of these patients will have a chromosomal abnormality of JAK2, the commonest, MPL, or calratinin. As the fibrous tissue replaces the marrow, the body starts having hematopoiesis outside of the marrow, extramedullary. And this extramedullary hematopoiesis occurs in the liver and spleen and leads to a very striking hepatosplenomegaly. This is a fairly aggressive disease. The median survival is only 4 to 5 years, and usually the death is due to a pancytopenia. When we take a look at the laboratory findings, remember, myelofibrosis is part of the spectrum of the myelophthisis diseases. And this means that when we look at the peripheral blood smear, it is leukoerythroblastic. And this is illustrated in Figure 7-8.3a, in which we see a nucleated red blood cell in the lower left, a so-called normoblast, and we see immature granulocytes, here illustrated by the arrow, as a myelocyte or metamyelocyte. Remember that it's a fibrotic marrow, and the stain classically for fibrosis is a reticulin stain, and we see this in Figure 7-8.3b, in which we have a bony trabecula on the right, and then all those black fibers inside the bone marrow represent the myelofibrosis. Neoplastic polycythemia should, remember, be just quickly compared to secondary polycythemia. Any cause of hypoxia is going to upregulate EPO, and that includes things like high altitude, lung disease, and the cyanotic congenital heart defects. Remember that the paraneoplastic erythrosecreting tumors most commonly are renal cell carcinomas and hepatocellular carcinomas. Bleeding disorders represent abnormalities of coagulation. The fundamental mental image we have to have in our mind is illustrated in Figure 7-9.1a. This is a very complex diagram, and it's not usable by staring at it. It's a diagram that the student has to be able to take a blank piece of paper and draw this out, his or her pen, from what you have in your mind's eye. So we're going to stop and draw out the normal now, illustrating this diagram, and then you're going to see how powerful this diagram is, because we can superimpose our diseases, our medications, and our laboratory testing on it. Remember that coagulation is homeostatic, meaning it's a balance of procoagulant and anticoagulant forces at the same time. We want to be able to restrict the coagulation solely to the area of injury. And we want to make sure there's no coagulation where there's normal, or we'll coagulate the whole body and turn into jello. So remember, at the same time the abnormal areas, the injured areas, are coagulating, the normal areas are anticoagulating, and that is mediated by the endothelial cell. So let's start with coagulation forces at the site of injury. Think of the body as the blood vessel painted with von Willebrand factor and then paved over with endothelial cells that keep that von Willebrand factor separate from the platelets. Anytime we have endothelial dysfunction, either by physical injury or cytokine injury, you can see what happens here in the figure. As we lose the endothelial cells, we expose the underlying collagen and von Willebrand's factor. That then allows the von Willebrand factor receptor, called GP1B, to bind to its ligand and activate the platelet. Activation of the platelet involves release of ADP from the dense granules. As well, COX is released from remnants of the smooth endoplasmic reticulum, which allows for the formation of thromboxane A2. Thromboxane A2 is going to have two very powerful effects. The first is it's going to cause vasoconstriction, and the second is going to massively amplify our coagulation effects. And remember, when we're talking about stopping bleeding, we're going to go from the molecular level to something as big as 2 or 3 millimeters in a matter of seconds to minutes. So that thromboxane is a really powerful accelerator. With the release of ADP from the dense granules, we get presentation of the GP2B3A complexes on the platelet membrane. This now allows that receptor to bind to fibrinogen. And obviously this cross-links with other adjacent platelets, so they also link to the same fibrinogen strands. And this now creates our soft clot. The hard clot is created when thrombin factor 2 clips the fibrinogen to fibrin, and we get covalent cross-linking bonds. So now the formation of the hard clot centers on thrombin and the coagulation factors. Physiologically, in vivo, the single most important pathway for the activation of thrombin comes from the tissue factor pathway. Tissue factor is found widely in many cells, and with injury, the exposure of tissue factor activates factor 7. Activation of factor 7 activates our common pathway of factor 10 and 5, again, as you notice, on the platelet membrane. This has to be kept in the area of injury. The factor 10-5 platelet factor 3 calcium complex now activates the thrombin. There's a second pathway starting at factor 12, which is very important in vitro lab testing. Factor 12 activates factor 11, which activates our factor 9-8-5 complex, which now activates our common pathway 10-5 platelet factor 3. Now come back up to factor 12, which you notice is presented in green, because this now cross-links to other systems. Factor 12 activates kallikrein, which is going to activate bradykinin, itself having many complex effects, including sensitivity to pain. Kallikrein activates high molecular weight kininogen to kinin, which is now going to reactivate in our intrinsic pathway. At the same time we've started this coagulation, we're going to limit it because high molecular weight kininogen activates plasmin, which you remember is a fibrinolytic protein. Plasmin activates the complement system with complement 3A, and now we see that this links to the inflammatory system. There is no coagulation that doesn't at the same time activate inflammation. Having done that, let's make this matter in a clinical way, because we're going to now start, as we see with our red markers, with all the diseases that we now understand are part of this pathway. The first is abnormalities of von Willebrand factor number 1. This obviously is von Willebrand disease. Abnormalities of the GP1B, the von Willebrand receptor, is what we see in Bernard-Soulier disease. Abnormalities of our GP2B3A complex is Glanzmann thrombasthenia. Deficiencies and abnormalities of factor 9 and 8 are our hemophilia B and A respectively. Remember, factors 2, 7, 9, and 10 use vitamin K as a cofactor, and so vitamin K deficiency leads to coagulation defects due to abnormalities in the factors with the asterisks 2, 7, 9, and 10. Lastly, remember that all the coagulation factors but 8 are made by the liver. As an aside, factor 8 is made by endothelial cells. So anytime we get advanced liver disease, classically cirrhosis, we're going to see coagulation defects because there is abnormalities of our factors. As well now, all of the drugs we use in managing coagulation and anticoagulation can be seen here. Obviously, the first one to start with are the COX inhibitors with number 1. These are our non-steroidal anti-inflammatory drugs. Drugs that block the activity of our GP2B3A complex is going to be clopidogrel. That blocks the ATP action. Actually blocking the receptor of the GP2B3A complex is epcizumab. Remember that thrombin, the central controller of the hard clot, is itself restricted by antithrombin 3. Heparin, which we see as number 4, increases the activity of antithrombin 3 1,000-fold. Warfarin blocks vitamin K, which we remember are the asterisk factors 2, 7, 9, and 10. More recently, we've developed drugs that are direct thrombin inhibitors, and we see this as number 6. This is very important when we have heparin-induced thrombocytopenia. Argatropan is a drug that illustrates this, but there are others. As well, we have factor 10 inhibitors, which we see as number 7, and there are multiple choices here, but exazepan is a good example. All of these drugs, you notice, end with a zapan, X for factor 10, ABAN. Last but not least, we can have plasmin activator, which is what we use as our common clot busters in fibrinolysis. The last thing we should be able to do with this diagram is take a look at our laboratory testing. Prothrombin time tests our tissue factor 7 pathway. Partial thromboplastin time tests our factor 12 through 8. Both of these, of course, also test the common pathway. If we come over and take a look at the integrity response to injury, bleeding time, a small nick in the skin, tests overall platelet function. If we're doing it in the laboratory, we can test platelet aggregation studies, and if we add ristocetin, we specifically are testing for von Willebrand disease. The last test we should imagine out of this are tests for fibrinolysis, such as D-dimer. So this is a really important pathway that really presents itself as a lovely summary of all of our basic sciences, drugs, and pathology for coagulation. As we look at page 745, Figure 7-9.1b now takes the surrounding normal endothelial cells, which have to protect themselves from coagulation and have anti-thrombotic activities. We should really think of this as having 3 antiplatelet activities and 4 antifactor activities. The 3 antiplatelet activities are production of prostaglandin I2, nitric oxide, which is a vasodilator, and ADPase. The 4 antifactors processes that we see include heparin-like molecule. Remember that heparin increases the activity of antithrombin 3 1,000-fold. There's a tissue factor pathway inhibitor, which makes sense when you realize that in vivo, tissue factor 7 is the most important pathway. Remember as well that there is a receptor, thrombomodulin, that is activated by the presence of thrombin. When activated, this then activates our protein CS complex, causing proteolysis of factors 5 and 8. The 4th antifactor pathway is actual release of TPA, which starts our fibrinolysis cascade. As with all pathways, we want to try to place as many of our clinical applications as possible. And we can see the number that work on this. Factor 5 laden, the commonest cause of hypercoagulability, is a defect in which the factor 5 is resistant to proteolysis by the protein CS complex. Thrombin can be produced in pathologic levels with the mutation prothrombin 20210A. Remember that antithrombin 3 is very important for the inactivation of thrombin, and it can be seen in 2 ways. The first problem can be a congenital deficiency, which is rare but well described, but we also see an acquired antithrombin 3 deficiency in nephrotic syndrome. Nephrotic syndrome can have such a profound loss of protein with a critical decrease in antithrombin 3, and 5% of our nephrotic syndrome patients will have renal vein thrombosis. Deficiency of protein CS, number 4, can be congenital, which is rare but well described, but the more important cause is acquired with the use of warfarin. Remember that warfarin affects factors 2, 7, 9, and 10, but also the synthesis of C and S. Factor 7 has a half-life of about 6 hours, and proteins C and S have half-lives of about 6 hours. So if warfarin is given and factor 7 drops first, your patient is successfully anticoagulated. If, however, C and S drop first, paradoxically, you've made your patients hypercoagulable. And so that's why in warfarin treatment, we always first start with heparin, because heparin is immediate acting and covers that risk period for warfarin. Remember, there's a couple of drugs we should think about here. Antithrombin 3's activity is increased 1,000-fold by heparin, and as well, TPA recapitulates the TPA endogenously released by the endothelial cell. So that's our basic science. How do we clinically approach the disorder? Well, let's just take a look at the tests that we have to do before we get to our clinical algorithm. Bleeding time was widely used for many years, but really isn't used in clinical practice anymore. It was very hard to standardize the small nick in the skin, and it led to scarring and infection, so we don't see it used anymore, but it's still described in the questions. Elevated bleeding time is seen with all platelet diseases and also connective tissue diseases because it requires tissue tension to actually close off the small cut. Mostly these days we use platelet aggregation studies, and by far and away the commonest disease is going to be von Willebrand disease. So remember that in a platelet aggregation study, the platelets do not aggregate in the presence of ristocetin. CBCs on all modern machines include a platelet count, and this is very useful for diagnosing our quantitative defects as opposed to the qualitative defects we diagnose by platelet aggregation studies. Prothrombin time measures the extrinsic pathway, also the tissue factor pathway, as well as the common pathway. This is probably the most common test we use for all of your patients on warfarin. Remember that most laboratories now standardize their prothrombin time through the INR, which references the laboratory's result to a national standard. This means that your patients can get the lab test done in Chicago in the summer and go to Miami in the winter, and they can correlate the two pro times through this national standard reference, giving the result as an INR. Partial thromboblastin time measures the intrinsic factor. It also is called the contact activation pathway, together with the common pathway. It is a test that's turned to be the most practical for monitoring heparin therapy, and basically it uses negatively charged substances like glass beads to initiate the coagulation, which is why it's called contact activation. Note that the PTT is similar but not identical to the coagulant cascade seen in vivo. When we're talking about investigating patients now, we really have to be very clear in how different the presentation is between platelet abnormalities and factor abnormalities. Platelet abnormalities occur with bleeding in very small vessels, and what this means is we see the bleeding in epithelium. Epithelium, by definition, is that layer of cells that covers surfaces. So we talk about epithelium as two fundamental types, squamous and glandular. So our obvious squamous epithelium is skin, and the bleeding we see is going to be petechiae. Bleeding from our mucous membranes is named according to what bleeds. So if you bleed from the nose, it's epistaxis. From the stomach, hematemesis. From the endometrium, menorrhagia. And from the colon, it can either be fresh bleeding, hematochezia, or bacterial arterial bleeding, which is black tarry melena. This is really different, note, than factor disorders, because they present with bleeding into soft tissues and joints. So when you're dealing with your patients, and by proxy your exam questions, the site of bleeding tells you what the defect have to be. If it's on a surface, it's platelets. If it's joint and deep soft tissue, it's factor deficiency. So petechiae, you'll remember, are due to platelets, and the bleeding is because platelets produce PCAM, the platelet endothelial cellular adhesion molecule. So when you get low platelets, you don't get enough PCAM produced, and you start getting leaky blood vessels, and you see the leaking as your petechiae. When you're talking about COX inhibitors, you still have normal PCAM production, so you don't see petechiae typically in nonsteroidal anti-inflammatory effects. Remember that acquired defects of coagulation are much more common than inherited defects. Acquired deficiencies include things like liver disease, warfarin therapy, vitamin K deficiency and malabsorption, and DIC, which is endothelial damage related typically to infection. Acquired platelet defects classically are low platelet counts of secondary thrombocytopenia, and, of course, NSAID use. Remember that inherited defects, when you read an adult history, there will typically be a history of bleeding abnormality in childhood. One of the rules of thumb I was taught as a young doctor and has served me well for many decades is this: if you can have a tooth pulled without a clotting defect, then that is a patient unlikely to have a hereditary disease. Remember that von Willebrand disease is the most common inherited coagulation defect. It has a wide spectrum of disease from asymptomatic to bleeding, and the commonest presentation is at menarche with refractive iron deficiency from menorrhagia. Of course, with all bleeding defects, we can manage bleeding by surgery or replacement therapy unless it's in the head. If the bleeding occurs into the head, we get increased intracranial pressure, and that certainly can be life-threatening. So then we come to the clinical approach to abnormal bleeding in Figure 7-9.2. And you can see we basically break it into two parts: platelets on the left and factors on the right. And you notice we've got one little carve-out for von Willebrand's, which we'll discuss. Your basic panel looking for coagulation defects is going to be bleeding time. This is an exam preparation course. Prothrombin time and partial thromboplastin time. If the only abnormality is bleeding time, we're looking for qualitative versus quantitative platelet defects, so we get a platelet count. If your platelet count is low, then you go to the bone marrow to see if it's a production versus a consumption problem. If the problem is an abnormality in the bone marrow, then the biopsy will show it. But if the bone marrow biopsy is normal and shows normal megakaryocytes, you know that it has to be a consumption problem, and that's ITP, idiopathic thrombocytopenic purpura. Over to the right in the green shaded area are our factor deficiencies. If you have an elevated PTT, we have to differentiate our antiphospholipid antibody from a factor deficiency. And the classic way to do that is with a mixing study. Think about this thought. If you are a hemophiliac, you do not bleed until your factor VIII level is less than 8% normal activity. So if I have an elevated PTT because of a factor deficiency, and I mix that plasma 50-50 with normal, that should correct. If it corrects, then you know you have a factor deficiency, but if it doesn't correct, you know you have an anticoagulant inhibitor, and that's going to be our antiphospholipid antibody. Isolated elevation of ProTime can only be factor VII deficiency, and when we see elevation of both PTT and PT, then we really have to differentiate: is it congenital, which means it has to be common pathway, 10, 5, 2, and 1, and if it's acquired, there are lots of diseases that do that, but I've just included a couple for consideration. So that would be deficiency of vitamin K and malabsorption, your patient's on heparin. We could have included other things like warfarin therapy and DIC. Now let's just have a quick look at the yellow shaded area, because you'll notice this is where von Willebrand disease is. Remember that the half-life of factor VIII is 2 to 4 hours. If, however, von Willebrand factor is introduced, then the half-life of factor VIII is more in the order of 16 to 20 hours. So in von Willebrand disease, we often see not only a marker of abnormal platelet function, elevated bleeding time, but we can also see an elevated PTT due to the short half-life of factor VIII. We confirm the presence of von Willebrand's disease because you notice we have the acronym RIPA, which stands for ristocetin-induced platelet aggregation, which is not present in von Willebrand's disease. Of course, you can actually just measure von Willebrand's antigen as a test as well for the quantitative defects. Other coagulation defects occur if there's vessel wall abnormalities. So that, for example, with our infections such as meningococcemia, we often see petechiae. The vasculitides can often be associated with petechiae, and in amyloidosis, we have weakening of the vessel wall with leaking. Remember, we're going to deal with this when we go to our amyloid vasculopathy when we get to the CNS system. Connective tissue diseases are also seen in Ehlers-Danlos syndrome and scurvy. Platelet abnormalities are very common. And usually you can tell what the cause is going to be if you know the age, the gender, the time frame, and you can do a physical exam with CBC and peripheral blood smear. Almost always, if it's a primary hematologic disease, you're going to see all cell lines affected, so you're going to see abnormalities in the red cells and neutrophils. Remember that day in and day out, it's going to be drug ingestion, especially your patients taking non-prescription and herbal remedies are going to be your most common causes of thrombocytopenia. So in the real world, as opposed to the testing world, having a really good history and knowing your patient well matters a lot. But overall, the presence of a low platelet count is a very common finding in medicine. And when we talk about the diseases with an increased loss of platelets, we have ITP, which we're going to talk about with our insert, heparin-induced thrombocytopenia, which we discussed in detail in Chapter 3, and then our microangiopathic diseases, which you'll remember are consumptive coagulopathies. So once we activate the coagulation process, we have the paradox of it being a hypercoagulable state, but as we consume all of the platelets and factors, we develop a deficiency state and hemorrhage. So let's just stop and consider ITP, because you're certainly going to see this in life and it's a good subject to test. The classic patient is going to be a young to middle-aged woman who's going to present with classic symptoms of platelet deficiency. Remember, platelet deficiency bleeds into epithelium. So it's going to be petechiae, epistaxis, hematemesis, menorrhagia. Not factor deficiency, that's deep soft tissue and joint. These women develop autoantibody-mediated immune destruction of their platelets, and the antibodies are usually to our platelet receptors, so that's going to be our GP2B3A, or less commonly our GP1B. Certainly they can be secondary. Lupus, HIV, CLL, all have this associated. But let's go back to our younger woman in her 30s, presents with the classic features of low platelets. You'll order your CBC and you'll have thrombocytopenia, at which point you'll go do a bone marrow and say, do I have normal megakaryocytes or not? If megakaryocytes are present, you know this is a consumptive disease, and that's good enough to diagnose ITP. Obviously, first treatment is going to be immune modulation with steroids, but with the failure of steroids, ultimately splenectomy may be necessary. HIV infection can cause decreased production of platelets as a specific primary part of the disease. Remember that HIV attaches to CD4 and CXCR4 on the cell membrane, and these are expressed on megakaryocytes. So actually, megakaryocytes can be directly destroyed by HIV infection. As well as we discussed above with ITP, immune dysregulation in HIV infection can also lead to the production of autoantibodies. Other causes of thrombocytopenia include large spleen. Remember, splenomegaly refers to large spleen. Hypersplenism refers to ill effects of the large spleen. Normally, about 30% of your platelets are held in an exchangeable pool in the spleen, but if you get a very large spleen, it can actually hold up to 90% of the platelets. Clinically, this doesn't usually respond to spontaneous hemorrhage because the platelet count typically doesn't drop below 30,000, and you don't tend to get spontaneous hemorrhage in thrombocytopenia till your count is below 5 to 10,000. No surprise, sequestration syndrome in hypersplenism can also have a neutropenia and also anemia. Qualitative platelet defects really are encompassed by two significant diseases. All others are quite rare. Von Willebrand disease is the most commonly inherited bleeding disorder. It's seen in somewhere around 1% of the population. Hundreds of variants have been described, and most of the variants represent quantitative, meaning a decreased production of von Willebrand factor. Remember, von Willebrand disease is associated with factor VIII deficiency because von Willebrand's factor stabilizes factor VIII. If your normal lifespan of factor VIII is 2 to 3 hours, it can be increased to 12 hours when bound to von Willebrand factor. So therefore, when we go testing for von Willebrand disease, we often will find an elevated PTT. If surgery is required, desmopressin can be given, which causes von Willebrand release through an unknown mechanism. Non-steroidal anti-inflammatory drugs inhibit platelet aggregation by inhibiting cyclooxygenase. and this therefore decreases the production of thromboxane A2. Just as a note, remember that acetaminophen is not considered a COX inhibitor, as it inhibits the COX-2 in the CNS, which gives its analgesic effect, but not in the rest of the body. Remember that most NSAIDs have reversible inhibition of COX. Aspirin, by comparison, has irreversible inhibition of COX. So this means that after aspirin use, several days are required for normal platelet function regeneration before surgery can be performed. A good example of this might occur if you wanted a liver biopsy to diagnose liver disease. Remember that liver is a soft parenchymal organ in which there's very little stroma for compression and stitching, so it's very easy to start bleeding and very hard to stop it. One of the questions you're always going to ask your patient before liver biopsy is, have you been taking over-the-counter non-steroidal anti-inflammatories? The answer is, if yes, which one? Because all the others that are not aspirin, remember that's reversible. So you can defer for a day and do your liver biopsy the next day. But if it's aspirin, remember, that's irreversible. Platelets have a half-life of 8 days. So you're sure as heck not going to go in and do the liver biopsy with less than half functioning. So you're typically not going to push it off 1 day if they're using aspirin. You're going to push it off more like 4 or 5 days. Coagulation factor defects really don't get highly represented on the exam. So they'll just be lightly reviewed here for purposes of discussion. Hemophilia A and B are clinically indistinguishable. They both have an X-linked recessive inheritance, and commonest pattern is familial, but 30% represent spontaneous mutations in the mother. They are classified from mild to severe. Note that severe is less than 2% factor VIII activity, and mild disease is 8 to 30% activity. They present with classic factor deficiency presentation, which means bleeding into joints, hemarthrosis, and deep tissue bleeding. These days they're treated with recombinant factor replacement. Remember that there are secondary coagulation factor defects in diseases such as liver failure. Remember that liver makes all factors except VIII, which is made in the endothelial cell. Malabsorption, remember vitamin K is a fat-soluble vitamin, so that when we have malabsorption, we can have vitamin K deficiencies. And remember that DIC, while it initially starts as a hypercoagulable state, is a consumptive coagulopathy that over time depletes both platelets and factors, and that leads to hemorrhage. This then brings us to an end of Chapter 7 on red blood cell pathology and bleeding disorders. At the end of studying red blood cell and bleeding disorders, the student must be able to start with a complete blood count and peripheral blood smear, and from it have a logical, organized approach to the diagnosis of the specific cause of the anemia. Each disease in anemia must be described in its presentation, its mechanism of disease, and the natural history of the disease in the patient. The student must be able to compare and contrast the CBC and the peripheral blood smear and its relationship to bone marrow examination. The causes of polycythemia should be familiar to a student, and how to differentiate relative, secondary, paraneoplastic, and neoplastic causes. The myeloproliferative diseases of polycythemia vera, primary thrombocythemia, and myelofibrosis must be understood by patient presentation, mechanism of disease, and natural history. In understanding coagulation, the patient must be able to, from a blank piece of paper, write down the normal pathways of coagulation, understand where in these normal pathways defects lead to disease, the site of action of the important anticoagulant medications, and which parts of the normal pathways are tested by different laboratory tests. Antithrombotic activities, including 3 antiplatelet activities and 3 antifactor activities, must be part of a student's understanding of coagulation defects, as well as the areas of abnormality that lead to hypercoagulable diseases. The student must be able to start in a patient with a history of abnormal bleeding and have an algorithmic approach based on a starting point of the laboratory tests of bleeding time, partial thromboplastin time, and pro time. A brief understanding of the platelet defects, including thrombocytopenia, specifically including idiopathic thrombocytopenic purpura, von Willebrand's disease, and non-steroidal anti-inflammatory effects, are an important part of clinical medicine and therefore important in preparation for the Step 1 exam. A brief understanding of hemophilia A and B is also important.